Thank you so much, Professor, for that session. There are no further question and answer in the chat box. If there are any other questions, if there are no other questions, then I would like to conclude this session. And the next session will be moderated by Professor Sumaira Farman.
Thank you very much.
Hi, Prof. Farman. Are you able to hear me?
Yes, I can hear you now.
Yes, Prof. You are online now.
Okay.
Yes. So everybody, now we are going to move on to the next session. The moderator will be Prof. Farman. Prof. Farman, please.
Good day. Konnichiwa. Assalamu alaikum. This is Sumaira Farman from Lahore, Pakistan. And I want to wish everyone an Eid Mubarak, which is what we are celebrating across the world. So it is my pleasure to moderate this session, which is on behalf of the Pediatric Rheumatology Special Interest Group. And I am based in Lahore, and I'm an adult and pediatric rheumatologist. It's my pleasure to introduce Professor Takako Miami, who's going to be speaking about contemporary challenges and future prospects in pediatric rheumatology in Asia. Dr. Miami is Associate Professor, Pediatric Rheumatology Institute of Rheumatology at the Tokyo Women's Medical University, Japan. She's also the present president of the Pediatric Japan Rheumatology Association. Her area of expertise encompasses rheumatic diseases as well as autoinflammatory diseases. And she is the principal investigator for the Health, Labor and Welfare Research Group at present. She is also contributing to a nationwide epidemiological survey on pediatric onset Takayasu arthritis and systemic scleroderma. In addition, she has special interest in adult and pediatric systemic lupus erythematosus, and she's going to be working on the immunogenic characteristics of pediatric systemic lupus. So over to Takako.
Mara, thank you for introducing myself. My talk is a little bit different from other speakers. So in this talk, I would like to share our pediatric SIG's activities along with our previous findings and future challenges. The SIG for pediatrics was launched during the APLAR conference held in Brisbane in 2019. Professor Sumaira Farman has been serving by the convener since its inception and continued to hold the position at present. We very thank her for her leadership and contributions. So far, there are 44 members from 19 out of 32 APLAR MNOs. The 19 countries are shown in color in this map. We need to expand the number of countries participating in the pediatric SIGs. As of 2021, the total number of children at the age of 15 is approximately 1.9 billion in the world and 1.2 billion in the Asia-Pacific region. These figures are based on the latest estimate from the United Nations Population Division. Pediatric rheumatic diseases are rare, very, very rare compared to adult rheumatism. And the exact number of patients with pediatric rheumatic disease, including connective tissue disorders, vasculitis, and autoinflammatory disorders is still unknown. However, the World Health Organization estimates the overall incidence rate of pediatric rheumatologic disorders to be around 1.2 per 1,000 individuals. From this information, we can estimate that approximately 2 to 4 million children with rheumatic disease in Asia Pacific region. So there are serious unmet needs in pediatric rheumatology in Asia Pacific regions. Unmet needs with top priority are shown here. Lack of understanding of epidemiology and medical care, and shortage of pediatric rheumatologists. At least in some countries and regions, there is a shortage of pediatric rheumatologists, thus highlighting the need for improved education and training for their cultivation. Countries with low GDP have the most percentage of young population, with least public health spending and the most shortage of pediatric rheumatologists. In this slide, let me share the situation of pediatric rheumatologists in Japan. In project, Pediatric Rheumatology Association of Japan, currently I am in charge of this association. The membership count is approximately 600 as 2022. Also, there are 114 Japan colleague of rheumatology board certificated pediatric rheumatologists. This may be a large number compared to other Asian Pacific Rim countries. Map of Japanese prefectures shows the distribution of pediatric rheumatologists. The left panel shows the actual number of pediatric rheumatologists, and the right panel shows the number of pediatric rheumatologists per pediatric population under 15 years old. Pediatric rheumatologists in Japan are mainly concentrated to urban areas. There is a shortage of pediatric rheumatologists in some areas when adjusted for the pediatric population. The countries shown are those participating in the pediatric SID. There is no country without children. The definition of a certificated pediatric rheumatologist in the Asian Pacific region is not standardized by region. However, it's very necessary to increase the number of countries participating in SIG and to recognize the directory of pediatric rheumatologists and the areas where there is shortage. Now we have 4 main missions as a pediatric SIG, as shown in this slide. I'd like to talk about each of these missions. The 4 missions are education of physician and the patient, formulation of an APLAR management guideline of each disease. 3, development of a registry in APLAR. 4, development of research collaboration.
Okay, I know. So, but how can I come back?
The COVID-19 pandemic has facilitated the widespread adoption of online seminars, which has been advantageous for our international exchanges. Through webinars, we are able to share knowledge on pediatric rheumatology, education, clinical experience, and their latest advancement. We have been conducting the series of webinars approximately 3 times a year since 2021. Primary focus is on the country in charge, where case presentations are given, followed by discussion and exchange of opinions. We hope to develop hybrid training program across the region. A course committee has actually been formed. Learning by case report may not be intensive or comprehensive enough. In project, with the aim of further improving the level of knowledge in pediatric rheumatology, e-learning sessions have been available on the website since last year. I showed just part of the seminar. New contents are being released sequentially this year. Unfortunately, the lectures are given in Japanese and limited to the project members. But if requested by the APLAR and if funds are available, we may be able to identify the contents in need and add subtitles or create an English version as our cooperated activity for this pediatric SIG. We are working on the APLAR management guideline. We think it is very necessary to develop the recommendations for the treatment of JIA in low resource setting. As you know, JIA is one of the major pediatric rheumatic disease. Several treatment guidelines have been published, including those in Europe and the United States. This is a guideline for non-systemic JIA issued by ACR in 2019. This algorithm is for the treatment non-systemic JIA proposed by Japan. I introduced some of the essence of the algorithm. Methotrexate is the only CDMARD approved for JIA. If the patient is intolerant to methotrexate or has an adequate response, a biologic agent should be applied. In Japan, there's a publicly funded medical subsidy program. Although the details of approved biologics differ from those in Europe and the United States, the application of biologics to severe refractory case is common to the Japanese algorithm. However, in low resource countries, treatment choice that follow the proposed treatment guidelines may not be possible for economic reasons. It is against this backdrop that we are working to develop JI's recommendation for cases in this situation. We aim and hope that this guideline will be able to apply to all Asia Pacific countries. which will also include countries with limited resource. In terms of this project, we are planning to upgrade the existing guidelines developed in the last 5 years using Agree 2 and use adapted to adopt the guideline. Also, we need to consider some concerns specific to Asia-Pacific region. We have to keep working on this project. Next, we move on the issue of registry. Pediatric rheumatic diseases are rare, but the registry is very important for the development of medical care and research. In Japan, the project has been operating a registry for several years. Primary data on about 400 cases were reported last year. GRA is the most common, as shown in this slide, followed by lupus and juvenile dermatomyositis. By subtypes of JIA, the systemic type account for 40%, and RF positive polyarthritis, RF negative polyarthritis, and oligoarticular type each accounted about 20%. This proportion of their subtypes may be different from other Asian countries. Ideally, a prospective registry is desired. The inclusion of a biorepository offers greater potential for clinical research, but operating a registry requires network organization, manpower, and funding. However, it's a great goal to be able to study the characteristics of case groups with Asian Pacific ancestry using the registry. Within Asia, difference can be inferred between the Far East, Southeast Asia, and the Middle East Asia. We believe that various collaborations are necessary for the development of pediatric SIG. There are academic pediatric rheumatology organizations, McCarroll in North America, and the press in Europe. But first of all, we need to build the ties within the Asian Pacific Rim. Our goal to establish ties within the Asian Pacific Rim and to promote collaboration with Europe and North America. We have to overcome the time difference and daily business and work together for the development of pediatric rheumatology in the Asian Pacific Rim. Thank you for your attention.
Thank you so much, Takako. Personally, I would like to appreciate this wonderful presentation, which is definitely not the usual that we expect, but so necessary to demonstrate to all of you in Japan and globally that pediatric rheumatology has such a crisis and critical shortage of health personnel who are trained in pediatric rheumatology. So I want to say thank you, wonderful presentation. Secondly, there are no questions, but I just would like to appreciate your offer of actually helping us with e-learning in enabling the rest of the APLAR region to access your e-learning modules. And I will write, and definitely APLAR would be in touch with you, and that would be absolute great service. So
I
thank
have
you
a question.
there again.
I have a question. I
Yes,
have.
please. Yes, please. Yes,
Yeah,
please.
it's a great learning that you have subtype systemic onset is more than others, because in that information is not known to me, at least. That is the advantage of why such, because world over probably it is the oligoarticular GIA. That's what I know about pediatrics. So how come it is only in Japan, or any other data from? I thought world over it is oligoarticular GIA which is more prevalent.
Yeah, as you said, in Europe and North America, oligoarticular account for the major part of our GIA subtypes. Yeah, it's different from, maybe it's due to the racial difference.
Thank you. May I respond to that? I think that's Ved who's asking that question. So the data that we have from Asia, particularly the subcontinent, which is India, Pakistan, Bangladesh, and areas within South East Asia as well, in Japan. So some of us in subcontinent, we see majority of polyarticular GIA or systemic, so which is worse prognosis generally. And so I will just reiterate what Takako has just mentioned, that oligoarticular is what is seen in Europe and North America. We don't know the reason, maybe it's genetics, but so it's all the more important for us in Asia Pacific to be able to pick up children and diagnose them early by training health professionals, because from the data that is available, they have a worse prognosis, these types of GI. So any more questions? Takako, that was an absolutely fantastic presentation. Really
Thank you.
enjoyed it. Thank you so much. Thank you. So I'm going to hand over now to the next session because we are running behind time. But thank you once again.
Thank you, Prof. Farman and Professor Takako. Now we're just going to move on to the next session, which is the session by the SLE SIG. The chairperson for this session will be Dr. Chi-Chiu Mok, and the speaker will be Prof. Sandra Navarra. Both of them will be online. Dr. Mok, hand over to you, please. Thank you.
So good evening, everybody. I'm Dr. C.C. Mok from Hong Kong. So I'd like to introduce our next speaker, Professor Sandra Navarra. Professor Navarra is the head of rheumatology at the University of Santo Thomas Hospital in Manila, Philippines. She is a steering committee member of Lupus Academy, executive board member of Asia Pacific Lupus Collaboration, and founding member of the Asian Lupus Nephritis Network. Professor Navarra is involved in a number of clinical trials of lupus and lupus nephritis, and has published widely in the field of rheumatology, including systemic lupus, SPA, and other rheumatic diseases. She is also awarded the Most Distinguished Physician Award by the Philippine College of Medicine and the Master Award by the APLAR. So without delay, may I call upon Professor Sandra Navarra to deliver her talk entitled Recent Progress in SLE Treatments.
Thank you. Thank you, Professor Mok, for the gracious introduction and for this opportunity to share the exciting new developments in lupus. And good afternoon, good evening, greetings from the Philippines, though it would have been great if I can join you in person at Hotel Okura. And here are my disclosures. A better understanding of the molecular pathogenesis of lupus has paved the way for developing new and more effective therapies targeting B cells, type 1 interferons, plasmacytoid dendritic cells, T cells, intracellular signaling, as well as toll-like receptors. The hyperactive B cells with production of autoantibodies are a hallmark of lupus, and B cell-directed therapies remain the anchor for drug development in lupus. Of these drugs, the chimeric CD20, chimeric monoclonal rituximab, has a colorful history in lupus drug development. And although the Explorer, which is the non-renal study, and as well as the Lunar, which is the renal trial, failed to meet the endpoints, post-hoc analysis showed clinical and serologic benefits, particularly in special populations. And rituximab now continues to be widely used in clinical practice, although off-label, but especially for severe flares and refractory lupus. The majority of immunosuppressants used in lupus exert their therapeutic effects on B cells, plasmablasts, and long-lived plasma cells, but not on the vigorous antibody producing long-lived plasma cells. Bortezomib is a proteasome inhibitor approved for treatment of multiple myeloma and has been used in a small study which has been shown effective for refractory lupus nephritis. And lately, zetomipzomib is a newer immunoproteasome inhibitor, and a phase 2 mission trial of zetomipzomib showed a clinical positive response in active lupus nephritis after 6 months. This is without high-dose induction therapy. Patients in the trial also experienced even reductions in the extrarenal manifestations of lupus. B-cell activating factor, BAF, or B lymphocyte stimulator, BLyS, is a key target molecule in B-cell pharmacotherapy for lupus. And belimumab, which is a fully human monoclonal antibody, selectively targets and inhibits BLyS, leading to increased B-cell apoptosis. And it is the first biologic approved for FDA for use in active SLE in 2011. Following the successful landmark belimumab phase 3 trials on BLyS 52 and BLyS 76, at least 2 other phase 3 trials have been performed, which reached the same SRI for primary endpoint at week 52. One assessed efficacy of subcutaneous administration, and the other assessed belimumab efficacy in a Northeast Asian lupus population, including Japan, China, and South Korea. Both trials yielded robust, significant outcomes, showing higher response rates with belimumab compared to placebo. BLyS-LN is a phase 3 RCT designed to specifically assess the effect of belimumab as add-on to standard of care in patients with active nephritis. And at the end of 2 years, more belimumab patients achieved the renal response efficacy of primary efficacy renal response, or PER, as well as the complete renal response, or CRR, endpoints versus placebo. And both endpoints were maintained to week 104 in the belimumab group. Moreover, the risk of kidney-related event or death at any time up to week 104 was actually 49% lower in the IV belimumab group compared to the placebo group. Now, findings from a recent pooled analysis of 4 phase 3 BLyS trials, which included 3,000 plus patients, and this is reported in Eurolupus T22 or last year, supports the use of belimumab and antimalarial agents in the prevention of renal flares. And the risk of flare was actually reduced in the IV belimumab 1 mg per kg group and IV belimumab 10 milligram group relative to placebo. But curiously, it's not seen in the subcutaneous belimumab 200 milligram group. The risk was also reduced with concomitant, as would be expected, antimalarial use. Atacicept is another biologic which works and blocks the effects of both BAF, or BLyS, and its homologous B-cell cytokine APRIL. And the phase 2 APRIL SLE Safety Committee, however, unfortunately, prematurely, and I would say incorrectly, terminated the higher atacicept dose. However, ITT showed this dose reduced the number of flares and time to first flare. Furthermore, the phase 2B ADDRESS trial showed long-term treatment with atacicept 150 milligrams in lupus patients and an acceptable safety profile with durable efficacy. Telitacicept consists of the extracellular domain of the human TACI receptor fused to human IgG, and the recombinant protein, which is similar to atacicept, was designed to inhibit both BLyS and the APRIL. And in a phase 3 study of 335 patients with active lupus, and this was conducted in China, subcutaneous telitacicept once weekly significantly increased SRI-4 response at 52 weeks relative to placebo. When he summarized the immunosuppressive and biologic therapies for antibody-related mediated manifestations of lupus, it is important to note that effective curative options need to eliminate both plasmablasts and long-lived plasma cells. Future therapies, which may cover a broader scope of these cellular targets to include sustained B-cell depletion by CD20 targeted chimeric antigen receptors, or what we call as CAR T cells, mesenchymal stem cell therapy, and the dual BLyS-APRIL inhibitor atacicept or telitacicept. In 2022, just last year, researchers reported outcomes among 5 patients. It's a small study who had severe and refractory lupus, and they were treated with anti-CD19 CAR T cell therapy. Within 3 months of treatment, 4 out of these 5 patients actually achieved a SLEDAI-2K score of 0. The 5th patient had an improvement in SLEDAI-2K score from 16 down to 2. And all patients experienced a sustained drug-free remission during the median follow-up of 8 months, even after B cells reemerged. So although this was a small study, it is worth looking into, especially for patients who have refractory lupus. Type 1 interferons have been found to play a key role in the pathogenesis of SLE. And there are 2 main cells that are involved in the production of type 1 interferons. You have your plasmacytoid dendritic cell leading on now and stimulating your interferon responsive cells. And the therapeutics targeting various aspects of this interferon pathway are actually in different stages of development. Anifrolumab is a fully human monoclonal antibody that directly binds to the type 1 interferon receptor. Following a refinement in study design gained from a conduct of TULIP-1, the TULIP-2 phase 3 trial of anifrolumab successfully met trial endpoints and has been approved in the US for the treatment of adult patients with moderate to severe lupus who are receiving standard therapy. And this is now the only new treatment, the second new treatment approved for lupus in more than 10 years following the approval of belimumab. Plasmacytoid dendritic cells produce type 1 interferons, and blood dendritic cell antigen 2, or what we call as BDCA2, is a surface receptor that is exclusively expressed on PDCs and is a negative regulator of type 1 interferon. Yes, sorry about that. Let me share this. Yeah, and yeah, unfortunately, just experiencing. Okay, so let's go back. Yeah, apologies for the technical problems. Yeah, so we've seen a lot of exciting exciting work being done. There's a lot of exciting action in the development of these new drugs. And as we go through these new drugs, including the newer drugs here, so talking about following anifrolumab, which is working on a direct inhibition of your interferon receptor, we now go into your the BDCA, which is found on the surface of your plasmacytoid dendritic cells. And here we have litifilimab or BIB59, which is actually a humanized monoclonal antibody that binds BDCA, resulting in downregulation
Prof.
of
Sandra,
type 1
so sorry to
interferons.
disturb you at the moment. You have
Oh.
not shared your screen to us.
Oh, okay. Yeah. So sorry about that.
No worries. Thank you very much.
Okay. Yeah, sorry. So now you can
Thank
see my
you.
screen.
Yes, we
you.
can see. Thank you very much, Prof.
Thank you. Okay, so now I was talking about litifilimab, and litifilimab is actually BIB59. It's a humanized monoclonal antibody that binds BDCA2, resulting in downregulation of type 1 interferons. And here, last year, there were 2 New England publications which featured the litifilimab trials meeting trial endpoints. One was for cutaneous lupus erythematosus, and the other one was for systemic lupus erythematosus. Now, just to go into a bit into mechanism of action, it's that blocks BDCA2 on PDCs, and therefore that leads to the downregulation of type 1 interferon. And in this phase 2 trial involving as lupus patients, litifilimab 450 milligrams administered sub-Q was associated with greater reductions in lupus disease activity, including active arthritis and skin disease. Immunoglobulin-like transcript 7, or ILT7, is a cell surface molecule which is specific to the plasmacytoid dendritic cells. And daxdilimab is a novel human monoclonal antibody that targets and binds to ILT7. Targeting ILT7 thus reduces the cells levels of your PDCs or plasmacytoid dendritic cells, therefore resulting now in decreased secretion of type 1 interferons. Phase 2 trials are now ongoing for daxdilimab in lupus, in SLE, and lupus nephritis, as well as other autoimmune diseases, including dermatomyositis. Lupus nephritis is always a hot item in lupus drug development on account of its high morbidity outcomes, even with standard treatment regimens. And illustrated here are the various therapeutic targets in lupus nephritis, including B as well as T-cell directed therapies and drugs which target the JAK-STAT signaling pathways. Voclosporin, or Lupkinase, is the newest generation calcineurin inhibitor, which is now FDA approved for lupus nephritis in 2021. Sirolimus, used in transplantation, blocks activation of T cells and B cells through mTOR inhibition and is being tried for extrarenal lupus. What about JAK-STAT inhibitors? Now, despite the promising results in the phase 2 trial, the phase 3 trial of JAK inhibitor baricitinib was unfortunately terminated due to its lack of efficacy. However, there were no safety issues. Orelabrutinib is an oral, highly selective, irreversible inhibitor of Bruton's tyrosine kinase approved in China for treatment of B-cell malignancies. In a phase 1b/2a dose-finding study in 60 patients with mild to moderate lupus, orelabrutinib added to standard background therapy and showed some promising clinical activity in lupus. Deucravacitinib is an inhibitor of a kinase called TYK2, which regulates signal transduction downstream of receptors for interleukin-23 as well as IL-12 pathways, and thereafter their type 1 interferons. That is included now in the PACE-LE trial. This is a phase 2 study wherein up to 58% of patients treated with deucravacitinib versus 34% of placebo-treated patients met the primary study endpoint of an SLE responder index 4 after 38 weeks of treatment. Deucravacitinib also achieved meaningful improvements in all secondary endpoints, and safety and tolerability profile was generally similar to placebo. And we therefore look forward to phase 3 trials of this drug. And here's our good old antimalarials. So antimalarials like hydroxychloroquine have long been used and found very effective for lupus. However, the mechanism of action was not made clear to us until the recent decades. Now we know that these drugs primarily work by blocking toll-like receptor signaling. And moving on from there, we understand that toll-like receptors, especially toll-like receptors 7 and 8, play important roles in immune surveillance. However, activation of TLR7 and TLR8 by ssRNA released from tissue damage may contribute to the pathogenesis of lupus. TLR7 activation in particular enhances B cell differentiation, increasing autoantibody production and immune complex formation. The TLR7 in PDCs stimulates type 1 interferon, as we heard earlier, and cytokine production, enhancing the immune response. TLR8 activation in PDCs, as well as TLR7 and 8 activation in monocytes and macrophages, stimulates production of pro-inflammatory cytokines. Notably, the increased intracellular NF-kappa B activation by TLR7 and TLR8 is actually associated and has been strongly associated with steroid resistance, and this, which is a major challenge in some lupus patients. So you might as well have a solution in these toll-like receptors. Afimetoran is a small oral selective inhibitor of toll-like receptors 7 and 8 that shows potent efficacy in preclinical models of advanced lupus. And the primary endpoint is SRI-4 at week 48. The estimated completion date of this phase 2 trial is by next year, May. And Enpatoran is another investigational oral selective inhibitor of your toll-like receptors 7 and 8. And phase 2 Willow trial will now evaluate the glucocorticoid-sparing effects of enpatoran in cutaneous lupus and as well as systemic lupus erythematosus. It's actually the glucocorticoid-sparing activity will be assessed with mandatory dose tapering to a prednisone equivalent of less than 5 milligrams per day, which is a very, very relevant and pertinent endpoint, especially for lupus patients, to bring down the steroids. The primary endpoint is the BICLA response at 24 weeks. At the risk of oversimplifying, I would like to summarize as follows. Targeting B cells actually include the first FDA-approved biologic belimumab, with now a 12-year track record, while rituximab continues to be widely used in clinical practice, as well as some now ongoing clinical trials. The human monoclonal antibody obinutuzumab is currently on phase 3 trials for lupus nephritis. Likewise, atacicept, telitacicept as inhibitors of both BLyS and APRIL, and the latest immunoproteasome inhibitor, zetomipzomib. Targeting type 1 interferons and plasmacytoid dendritic cells include drugs that have been developed like anifrolumab, which is only the second FDA-approved drug for lupus, and the recent litifilimab and daxdilimab, now on phase 2 to 3 trials. Primarily targeting T cells and to some degree in sync with B cells are the newest CNI voclosporin, approved also for lupus nephritis, in addition to the older CNIs like cyclosporin and tacrolimus, which are still widely used in clinical practice. mTOR inhibitor sirolimus, and the attractive novel CAR-T therapy. Intracellular signaling inhibition of JAK-STAT is done by baricitinib, which we know was promising in the phase 2 trial, but not in the phase 3 trial, but nonetheless, there were no safety issues. So we still look forward to that because interestingly, baricitinib has also been used in dermatologic cases like alopecia areata. And TYK2 inhibitor by deucravacitinib, as in the Paisley trial, and Bruton's tyrosine kinase inhibitor, or BTK inhibition by orelabrutinib. And finally, toll-like receptor inhibition by the good old hydroxychloroquine, which is a must in patients with lupus, as well as the newer drugs right now on clinical trial, afimetoran and entaporan. Indeed, there are many more, including repurposed drugs, including secukinumab or combination drugs like rituximab with belimumab, or even novel drugs in the future. However, in lupus, we know that there is no one size which fits all. Indeed, despite the advances in drug development for lupus, there remain patients who simply refuse to respond to current therapies. And therefore, we need more of this. Lupus presents with an exceedingly wide range of manifestations, from quiescent but serologically active to major organ involvement. And no two lupus patients are ever the same. And it cannot be overemphasized that treatment should be highly individualized. We have struggled with lupus drug development for the last 30 years, but I am optimistic about the future. We will have new targets, we will have new strategies, we'll have more medicines, we'll have better prediction from biomarkers, and definitely better trial designs and endpoints. And this means better outcomes for our patients with better quality of life. Let's continue to find solutions for lupus. Thank you.
Oh, thank you very much, Sandra, for your excellent update on the treatment of lupus. Any questions online and also in Japan? I cannot see any online questions. Maybe I start by asking you a question. Coming back to the real world, we only have a belimumab, rituximab, and perhaps newer CNI in US, but not yet available in Asia yet. So what will be your choice for patients who do not respond optimally to the standard of care? So any expert opinion on this belimumab, rituximab, and also the CNI?
We know that one of the challenges, especially in our part of the world, is not just this access to new drugs, but it's also the adherence to medications. So I would just first, number one, make sure that they're adherent, because we still have, and I'm sure you agree with me, CC, that we have effective therapies available with us. But the main roadblock that we have with our patients is still adherence. So we do with whatever we have available. And there are many repurposed drugs that are available, repurposed, including leflunomide for some cases, which we use in rheumatoid arthritis. And there have been studies that show that leflunomide can be effective for these patients as well. But I would like to stress, it's so important to have them go in adherence for these patients to be adherent to their therapies.
I think it's important for ensuring treatment adherence and also early referral to a specialist for assessment. But practically, I was asked many times about the CD20 biosimilar and also the belimumab. You know, the biosimilar is now readily available in many Asian countries. What do you think? If a patient has refractory lupus manifestation, will you use belimumab or any CD20? Biosimilar, that's on the course, yeah.
Yeah, well, whatever is available.
Mm-hmm.
We know that in the course of the development of the B cell, there are parts of the B cell development or maturation wherein belimumab works and rituximab doesn't work, and vice versa. That is why we have these combination therapies wherein you can use rituximab as an induction and then follow it up with maintenance with belimumab.
Okay, I see two questions online. So the first question is, will B-cell depletion therapy, with B-cell depletion therapy in lupus, did you follow the CD19 counts or the serum IgG level?
Yeah, there are studies that show that if you have patients who do not seem to have any depletion of their B cells are actually, they're not, these are the non-responders to your rituximab. I mean, it does make sense. So that may be one option of following them up with B cell depletion. If you find that your CD19 levels are not going down, then maybe your drug is not working. Or or maybe there are other mechanisms that you need to explore in your patient that are happening in your patient other than B cell mechanisms, pathomechanisms. So, and I see another. Do you recommend the step-by-step? There's a question. Do you recommend step-by-step treatment or multi-target treatment from start to avoid higher steroids or long-term effects? In general, I will answer. I'm sure you agree with me. The earlier you treat these patients, the better. And the more aggressive you treat these patients, the better. So I would go ahead and use multi-target. But just be careful with multi-target because you can go into safety problems, aside from the cost.
So, okay, how about the IgG level? So personally, I will check the IgG level as baseline before rituximab or belimumab therapy as a baseline. So if for repeated courses of rituximab, maybe some patient may develop hypogammaglobulinemia. So we may need to monitor for the IgG level. Do you agree with this?
Yes, because that is the one that's directly related to the risk for infections following B cell depletion therapy. So instead of the CD19.
Yeah, CD19 is not available in many centers, but serum IgG is easily available. So I will check the baseline and monitor if the patient is on prolonged therapy with of the B cells like belimumab and CD20. So, any other questions online or at the meeting?
Can I ask a question?
Okay. Who is talking?
Prof. Ahmad?
Oh, Dr.
Yes.
Ahmed. Yeah.
Hi. Yeah, excellent talk. Wonderful. I have a question. What is your experience with belimumab in membranous nephritis?
I don't think there are any studies on membranous nephritis alone. So there are purely membranous nephritis. None. And even in the BLISS, even in the BLISS LN trials, I think they have excluded pure class 5 nephritis. So it has to be, you have to have proliferative lupus nephritis, which is class 3 and class 4. And they can be combined with class 5, but you have to have the class 3 and class 4, but not pure membranous nephritis. So there are no studies for pure membranous nephritis.
Thank you so much. An excellent session. Great, Sandra. Thank you.
So if there are no more questions, I will hand over to the next section, the chairman and also the speaker. So thank you very much for listening to this SLE talk.
Pleasure for me to introduce the next speaker, Professor Mishimasa Kishimoto. He's currently serving as an associate professor at Kyorin University School of Medicine. So after his training in Japan, he had his internal medicine residency at Hawaii and then rheumatology fellowship at New York University. And afterwards, he was the program director of the Department of Rheumatology at the Kamida Medical Center, and afterwards, St. Luke's International Hospital, before moving on to accept his current position in 2019. So Dr. Kishimoto was certified by the American Board of Internal Medicine and Rheumatology, and he also received an ASIA Distinguished Fellow Award in 2006. He's also a steering committee member in the APLAR Guideline for Management of Rheumatoid Arthritis, as well as SPA, and is currently the APLAR SPA SIG member, and also JCR Guideline member, and he's also GRAPPA and ASAS member. So he also have over 100 publications in major journals. So without further ado, may we ask Professor Kishimoto to tell us what is new in PSA. Professor Kishimoto, please.
Thanks, Leishan, for kind introduction. So it's my great pleasure to present my topic today, the what's new in PSA. And thank you for organizer as well, and Dr. Danda. And here is my topic today. I'm Dr. Kishimoto. I'm an associate professor in clinical Kyoto University School of Medicine. And I'm gonna focus on the PSA today regarding clinical features and treatment. Firstly, always start with the case. Here is my patient. I wrote the clinical feature PSA review a couple years ago. This patient came into room. Do you see, what do you think? So here is a published surface because the endothelial organs system around, and also ray phenol diversity, and some fusion there, and then oil dropping nails, and then distal involvement, DAP involvement. You can see this might be PSA just firsthand. And this is important information from the Alexis Grappa member. She used the Corona, now called Evista registry, around 350 patients who started the biologics. Two-thirds of them have more than 3 domains. The 5 domain nail and skin divided, and a 6 domain, and then 3 or more domain when you start the biologics. So when you start the biologics or any treatment, you have to see what type of domain the patient involved. And then here is the EULAR recommendation, currently 2019, but in next EULAR in June, May, they will present the new EULAR recommendation. I got the new informations. And then here, the 2019 recommendation, the polyarthritis monoenthesitis actual disease domain. Then here, dactylitis is attached to the polyarthritis. Why? It's according to the expert, that's the categorized as a poor prognosis factors. So social digit dactylitis often seen in the patient with the PSA. That's one of the key. But you have to take off the socks, because according to the PSA cohort in Toronto, 500 patients, and half of them have dactylitis, but the 2/3 of them have toe only. So you have to take off the socks. And then here is the new information from the leads, Helena and Halliwell. They published the ARD last year around the 177 patients with the PSA. And then half of them have dactylitis. And then who had a dactylitis had a more damaged. And then dactylitic PSA versus non-dactylitic PSA, they showed the around 2/3 of them have polyarthritis with a dactylitic PSA. In opposite, oligo is main in the non-dactylitic PSA. And then they look at the ultrasound and non-dactylitic versus dactylitic PSA. Important thing is here, US erosions. Around 12% of the non-dactylitic have erosions, so the ultrasound. However, dactylitic PSA have more. 30% of them have erosions at ultrasound. And how about actual disease? I'm going to go into the next topic. Actual PSA was reported to be 25 to 70% of PSA patients. It's wide range. Why? Because there's no classification criteria. Now, ASAS and GRAPPA are working on the AXIS study to develop the classification criteria and the nomenclatures of the actual PSA. Here is the two different disease probably associated with the B8 bilateral but asymmetric disease, and more perpendicular non-marginal syndesmophyte. And this is my patient with the PSA, the isolated neck lesions. It can be seen in a PSA patient, so be careful. And here is the AXIS study that's ongoing. This is a new information from the Toronto team again. Daphna wrote this one, around the 1,300 PSA patients. Among them, around half of them have axial involvement defined unilateral grade 2 SI. Then they follow more than 5 years, and then 150 patients are followed for more than 5 years. And then half of them progress to the AS defined by New York criteria. So who developed the New York criteria? So this multivariate analysis showed the high PASI, I'm sorry in Japanese, but the high PASI score and also peripheral joint distractions, and also male gender. That's associated with the risk factor to develop the progressions of the actual involvement. And then protective factor is the degenerative disc disease. So you think that's the dish or other degenerations, then the progression rate is lower. Another report from China published last year, actual PSA with without dactylitis again. So dactylitis actual PSA patients have more damage and high activity, according to the China data. So, okay, so dactylitis and actual disease. So let's move on to the treatment. The GRAPPA recommendation just published last year. Here is the 2015 criteria. Domain is big change, actually. Oh, sorry. Oh. So here, the comorbidity divided into the related condition, including uveitis and IBD, and then rest of the comorbidity is there. And then joint and skin domain unchanged. And then since 2020, lots of information from IL-23 inhibitor studies and JAK inhibitor, especially upadacitinib, data published. And so they added the we added the IL-23 and then JAK inhibitor in each domain. And so what is the new treatment options? Here is the lots of, selections. So which you like to treat the patients with the PSA. And here is the PSA comparisons, ACR20 response at that 6 month overall study is not head-to-head comparisons, but here's the TNF inhibitor ACR20 rate. Here is the percentage of the bio users in the different clinical studies. And here's the ustekinumab and IL-17, batacept, 23 inhibitors, oral agent, the JAK inhibitors. Here is the upadacitinib, and the others, tofacitinib, and apremilast is the last. So it's great to see this, information and many choices in the daily practice. So firstly, I'm going to touch the new information for TNF inhibitors. A patient who failed the methotrexate 50 milligram and randomized to the adding adalimumab to methotrexate 15, and or escalating methotrexate to 20 to 25 per week. Which one you like? Adding TNF or increasing the methotrexate? Here is the answers. At the 6 month here, the achievement of MDA, minimum disease activity, the adalimumab adding group, 41% versus 13% in the escalating methotrexate group. So much better response in adding TNF inhibitors. Next would be a head-to-head studies. So when you look at the head-to-head study, important to see clinical trials are being conducted at the doses that are likely to be more effective than the already approved drugs. So the TNF inhibitor already approved. Then next one, the IL-17. So they set the higher doses who beat the prior approved drugs. So then 23 inhibitor there. Then they set the doses, compete the previous, the IL-17. So here is the result: ixekizumab versus TNF inhibitor, and the combined response of 50, ACR 50 and a PASI 100. As you know, the ICSI head-to-head studies are 36%. The ICSI, I'm sorry, 36% versus 28% in TNF adalimumab group. And then secukinumab was saying again, the similar efficacy in ACR 20. On the right upper side, the PASI 90 scores are much higher in an IL-17 secukinumab group. As I said, the doses set higher dose to beat the prior approved medications. And how about the IL-17 versus 23 inhibitors? Again, so 23 is a later approved medication. So again, beat this IL-17. So here is the golimumab, guselkumab versus secukinumab. How IL-17, you gave loading doses, so faster response. So I choose the patient with the facial or scalp psoriasis or much QOL damaged PSA patients. However, the safety and also the sustained rate is higher in the guselkumab. How about the risankizumab? Here is the PASI 90 response per risankizumab versus secukinumab, IL-17. Again, IL-23, risankizumab beat the secukinumab. Here's the ixekizumab versus guselkumab. At 12 weeks, they loaded, so the higher chance to get the PASI 100, 41%, the ICSI group versus 25, the guselkumab, but it's about the same on the cross at the 6 month. And a newcomer, bimekizumab, that's IL-17A and F inhibitor. And here is the New England Journal published Radiant studies looking at the plaque psoriasis, moderate to severe plaque psoriasis, bimekizumab 320 milligram versus secukinumab 300 milligram. They showed the superior response, and looking at the PASI 100, bimekizumab has a superior to the secukinumab. But in the bimekizumab group, when you look at the side effect, the oral candidiasis around 18% versus secukinumab at a few percent. So as you know, the IL-17 is the barrier in the mucous membrane, so the increased risk of candidiasis. So we knew, but it's a high chance if you use a 320 milligram dose. But patient with the SPA data that just published in Lancet, they used the 160, the half dose of the used in the PSA studies. So here is the meta-analysis, always looking at the response, PASI 100 versus 75 here, the IL-17 and also 23 inhibitor is the higher. So in the daily practice, when the patient have a severe skin disease, you may choose the IL-17 or 23. And another important information from the Maximize study that's published a couple of years ago, that's a secukinumab, the first clinical trial for the actual PSA, showed the better response compared to placebo. You're looking at the best ASAS-20 response is higher in the secukinumab versus placebo group. So IL-17 versus 23, both safer, maybe, but the FDA label only the radiographic response only for IL-17, not for IL-23. So that's different. That's important in the rheumatologist. You know, there's no clear primary endpoint for the radiographic response in the 23 inhibitors yet. And the future research in data, as I said, as showing here, the combination therapy or sequential biological therapy, or we have a new JAK inhibitor, actually the TYK2 inhibitors may be much safer. And bio, we may see the future combination therapy PDA4 apremilast plus bio or TYK2 inhibitor plus bio. And here, how about the future combination therapy? So here is the different disease you see ulcerative colitis. This is a Lancet Gastroenterology Hepatology, just published. They randomized the combination therapy guselkumab plus golimumab, TNF plus 23, and a monotherapy group, both, the 3 arms. And then combination group has higher response. So in this trial, mirrors the PSA studies too in the future. So combination can be possible. And as you know, in the rheumatoid arthritis population, I remember in early 2000 or we knew etanercept plus anakinra, and another study showed etanercept plus abatacept, both looking at the response, and then maybe better response. However, both studies showed the increased risk of infection, especially sepsis. So we knew that as a rheumatologist, we never touched the combination therapy. After that, two important studies. But however, here, so we knew IL-17 and IL-23 is very safe. So they combine the other biologic therapy. So we can see the different features in the long run. Here is a sequential therapy, IL-17 and IL-23. And patient who failed, George published here in the ARD, 3 patients who failed the monotherapy with TNF and IL-17 and 23, and then did IL-17/23 sequential at the same time, they had a better response. Here, the 3 patients. And then how about the oral therapy? Post-COVID era, maybe oral therapy has a simple and then flexible, the visiting hospital, and then you can carry the tablets anytime. You don't have to carry the syringes in the fridge. So it's important for the patient if it's safe and effective. So first one, the upadacitinib, SEDAC PSA1, and we have 2 studies as well, but here's a 1 study compared to adalimumab. This is a 30 milligram dose, not approved dose in Japan. Approved dose here, the 50 milligram. The numerically higher response, ACR 20, and a similar response, ACR 20. PASI 75, a little bit better in the upadacitinib group. How about the TYK2 inhibitors? It's TYK2 inhibitor is selective TYK2 inhibitor. It's attached to the pseudokinase domain, not the kinase domain. So do not block the other ATP domain. So purely TYK2. So this TYK2 inhibitor doesn't inhibit the interferon gamma. So that's the maybe the safety is similar to those in the apremilast. So the ACR20 response is at 63% deucravacitinib group. Here's a 12, but approved dose will be a 6 milligrams. So ACR20 is a 50%. So a little bit, lower response to the other, but it's very safe. And the label of the approval was same as apremilast in the FDA in Japan as well. What's the tapering? Only 1 slice. So here's a T2 tapering of a TNF inhibitor, randomized PSA patient, a SPA patient to tapering schedule dose, and then 2-to-1 ratio. The one group has continued the 2-to-1 ratio to treat to target tapering. Then you can see that you can taper, nicely. And if you flare, then you can go back to the previous dose. Then the half the patient achieved the 50% reduction of the bio use. So it's good for the safety and also cost issue as well. How about the precision medicine? Here is only 1 slide. Yoshia Tanaka group published a couple of years ago, 3 years ago, looking at the peripheral bloods, CXCR3 and CXCR6, and then divided into the different algorithm. And they showed if you follow these peripheral blood precision medicine, MTXIR PSA patient, then higher chance to get the ACR 20 and a 50 and a PASI maybe 75 response. So in the future, we can see the precision medicine. I think Binod and Grappa team working on the biomarkers who developed the PSA and psoriasis or who responded to biologic therapy. Lastly, how early do you treat? As you know, the Jose published in the Nature Review Rheumatology, PSA, this is a prodromal subclinical. We have many studies seen like on an osteophyte ultrasound in QCT, and maybe prodromal subclinical PSA, but not yet defined what's the which patient definitely developed the PSA. So we knew the risk factor to develop PSA, the nail dystrophy and scalp psoriasis, and also intergluteal psoriasis and the severe psoriasis as well, and others like family history of PSA and obesity, also the smokers. That's the other risk factor to develop PSA. So here's the, can we prevent the PSA patient with the psoriasis? And according to the Italy study, it's a moderate severe psoriasis, and they follow at least 5 years. One group, 5 bio users, and other group, 3 course of narrowband UVB therapy, and 230 patients each group follow more than 5 years. Here is the result, around the 70% reduction in the bio users of PSA incidence in the 5 years. So it may prevent the PSA. So as a rheumatologist, we may not see much PSA in the future if the dermatologists use a lot of bio at the first hand. And However, here's the other opposite result from the Alexis group from using the electoral database in the US for the 10 years. This is also retrospective studies. They showed the UV therapy versus bio users. This the incidence of PSA is lower in the UV therapy group. And then IL-17 users is the highest to develop PSA. As you know, we knew patient had a severe psoriasis. You choose the IL-17s, then you have a high chance to get the PSA in the future, right? Because at the baseline, they have a severe psoriasis. So in the retrospective study, see like this. We understand that. But Alexis updated. So when they developed the PSA, interesting. So bio users develop PSA within 1 year. What? So she said, maybe overlooked. Derm people overlooked the psoriatic arthritis. So, collaborations, derm and rheum is important, as you know. Here's the PAMPA study, the GRAPPA study. Now it's ongoing studies, rheum derm clinic from Canada and then, also USA. And PAMPA study can see patient who had a psoriasis with a risk factor to develop PSA, randomized to 23 inhibitors versus just regular treatment group. Then follow 2 years, and which patient developed a psoriatic arthritis, and they do check the biomarker ultrasound, also stool as well by Jose. So here is the last slide. Thank you very much, chairpersons, Lei Shan, for having me in this wonderful seminars. And please enjoy JCR annual meeting. Yoshia Tanaka led this JCR. Wonderful day. Thank you very much.
So thank you very much, Mish, for this excellent summary. So the floor is open for questions, and yes.
Thanks for an excellent lecture. I just wanted to ask, since neck involvement goes unnoticed sometime in a 40 years, 45 years female, dumped as a osteoarthritis or a cervical spondylosis, and which is the good modality to see the neck? Even if you do MRI, it won't come. People are poorly trained for seeing they will only see the osteophytes, probably, maybe they'll write just osteoarthritis. Though we are fairly convinced, what our observation had been that suprascapularis, this sometime, if you do ultrasound of suprascapular, you can pick up there, because not only exactly neck, it is the suprascapular muscle. That is, I just wanted your comment.
Yeah, great questions. I have no answer, but in the clinical situations, we knew that patient who elderly persons, dish is very common, 50% prevalence in age older than 80, they have dish. So how do you differentiate? It's hard. Because when you have a patient PSA with the osteoarthritis, erosive OA, it's difficult to differentiate, even ultrasound. Ultrasound can pick up the synovial inflammation, the power Doppler signal in the erosive OA as well. It may be CPPD involvement. It's difficult. But also we need to know the actual involvement of PSA, often seen without inflammatory back pain. According to Daphna's and also George's group also said only 40% have IBP. So 60% actual PSA have no IBP. So just a neck stiffness and a pain, then we have to screen. Always lateral view of the lateral, because it's a higher radiation exposure compared to the chest X-ray. So in the spine X-ray, always get just the lateral view. And then if you think it's suspicious of longitudinal follow-up, then you have persistent pain there, I will get the MRI, because the MRI can pick up the around soft tissue involvement, enthesitis and capsulitis around, also facet joint, lucica joint inflammations, also spinal process enthesial involvement as well. So in then tell it may be PSA. So also you can see the multiple lesions at the spine. The Hong Kong group showed a SPA patient MRIs and more than 4 or 3 spine lesions, maybe SPA then compared to less than 1, less than 2, then that's maybe degenerative disease.
Okay, so yeah, we have next question.
Thanks, Mr. Vishu. It's a very nice summary of this one. I think for the Ved, I can say the one modality is in our setting, something like that. If somebody does have the symptom, a lateral view of this neck, spine, and the presence of the skip syndesmophytes, robust syndesmophytes may help to make the diagnosis. My question is that if dactylitis is there, among of the drugs, which one you just think must better in the outcome?
Oh, you mean the
which drugs
inhibit the progressions?
I think improvement and others with.
Well, the peripheral joint, I use the sulfasalazine, the methotrexate, but as you know, these are not for the interstitial organ system treatment. So I choose the conventional synthetic dimers, but rapidly escalating to the bio. But I would choose the conventional synthetic dimer first.
Even with the presence of dactylitis. Yeah, that's good.
Yeah, because sometimes difficult, only monoathletic and then DIP and PIP, and then looking at the ultrasound, then there is dactylitis in between interstitial organ damaged. So it's difficult per clinical examination. So I choose the conventional synthetic dimers.
It looks the prevalence of dactylitis is much higher from the study you have shown.
Right, polyarthritis.
Yeah. Thanks.
You're welcome.
So do we have any further questions? If not, then we would like to thank Professor Kishimoto again for the excellent presentation.
Thank you all.
And I think we will have like 10 minutes break. So we will come back in 10 minutes. Thank you.
Welcome back to the APLAR Midterm Symposium, State of the Art Advances in Rheumatology. Right now, we're going to move on to our next session by the crystal-induced arthritis SIG. Today, we are pleased to have Dr. Ronald Ip to be chairing this session. And speaking with us today will be Dr. Jose Pola Lorenzo. Dr. Ip, please.
So thank you very much for staying and behind for the next sections of the symposium. So the next symposiums will be delivered by Dr. Lorenzo. Dr. Paulo Lorenzo is the chief of the section of rheumatology in Makati Medical Center. He is also an active consultant at Asian Hospital and Medical Center. He is also part of the training committee in the section of rheumatology at UP Philippine General Hospital. He took his medical degree from UP College of Medicine, trained in internal medicine at Philippine General Hospital, and then took his fellowship in the rheumatology at Philippine General Hospital and pursued his clinical and research fellowship in rheumatology at Medical College of Wisconsin's affiliated hospitals. He was a former president of the Philippine Rheumatology Association and is also a very active member of the Medical Alumni Society. So without further ado, we would like to give our time to Paulo. Thank you.
Thank you, Ronald, and good evening, everyone. And I'd like to thank the organizers of the APLAR Midterm Symposium for inviting me here today. I am here representing the crystal-induced arthritis SIG. So my topic for today is cardiovascular morbidity in gout, lifestyle factors matter. And the outline of my talk, I'll mention the prevalence of cardiovascular diseases in gout, then the biological effects of uric acid on the cardiovascular system, the evidence of gout's effect on cardiovascular disease morbidity and mortality, lifestyle factors, diet and exercise, and I'll end with actually a drug for diabetes, SGLT2 inhibitors, and hyperuricemia. So gout is the most common form of inflammatory arthritis globally. Worldwide, the prevalence range of gout in the 60 to 69 years group is 1.5 to 8.8%, depending on the country that did this study. But if you notice in the table below that as you age, the prevalence of gout also increases across the world. What about the prevalence of cardiovascular disease in gout? So pooled prevalence estimates were calculated for 5 cardiovascular diseases: myocardial infarction, 2.8%, heart failure, 8.7%, venous thromboembolism, 2.1%, cerebrovascular accidents, 4.3%, and hypertension, a high of 63.9%. Of course, the confidence interval of this is quite high. And from these pooled estimates, actually, there were about 16 studies that compared non-gout versus gout prevalence, and across all the different cardiovascular diseases, those people with gout had a higher hazards ratio or relative risk for the development of a cardiovascular disease. So for example, for myocardial infarction, it ranged from 1.12 to 2.08. Heart failure, 1.97%, cardiovascular mortality, 1.58, and all-cause mortality, 6.75, atrial fibrillation, 1.21, 1.92, and angina for females, 1.28. So definitely the risk for cardiovascular disease in gout is higher. So what is it that uric acid possibly does to increase cardiovascular risk? Well, when the monosodium urate crystal enters the cell, it has some intracellular effects. For example, it activates the nuclear factor kappa beta, and the systemic effect is inflammation. It activates your mitogen activated protein kinases and growth factors, which produce or drive proliferation of cells. It stimulates vasoconstrictive substances such as angiotensin II and endothelin, causing hemodynamic alterations. And it causes oxidative stress, which decreases nitric oxide, and this can cause endothelial dysfunction. Now, with knowing this, what does it do then clinically? And we want to find out if gout and hyperuricemia contribute to the development and progression of cardiovascular disease. Unfortunately, there's a paucity of information regarding this particular question. And there was just one study back in 2011, which put together several studies to ask the question whether uric acid was an independent predictor of cardiovascular mortality. And so there were two studies from Italy, one from Australia, and one from the US. And the outcome definitions of all these studies were cardiovascular disease mortality and or total mortality. And of these four studies, 3 said yes, that uric acid was an independent predictor of cardiovascular mortality, and 1 said no. So we got conflicting results. So does treatment of gout improve cardiovascular disease outcomes? There are many studies on this. Some are randomized controlled trials and some are systematic reviews. But if you look at the first study, which asked the question, what is the effect of urate-lowering treatment on the incidence of major cardiovascular events, acute all-cause mortality, and kidney failure events? The endpoints were all the same, but the conclusion for this particular study was urate-lowering therapy did not produce benefits on the clinical outcomes, including major adverse cardiovascular events, all-cause mortality, and kidney failure. So the next two studies in this slide are the CARES trial and the FAST trial. They just determined whether febuxostat and allopurinol were comparable with each other. Now, with the CARES trial, it was the outcome of this trial. It was in 2018. Outcomes for cardiovascular events and death. The conclusion of this study was that in patients with gout and major cardiovascular coexisting conditions, febuxostat was non-inferior to allopurinol, which is good with respect to the rates of adverse cardiovascular events. However, all-cause and cardiovascular mortality were higher with febuxostat than with allopurinol. And this is what prompted the ACR to actually modify their guidelines in 2019. The next study was the FAST trial, which actually refuted what the CARES trial said. And the question was, is cardiovascular safety of febuxostat comparable to cardiovascular safety of allopurinol? This was a randomized controlled trial, 6,000 subjects. The outcome was non-fatal stroke or cardiovascular death. And they concluded that febuxostat is non-inferior to allopurinol therapy with respect to the primary cardiovascular endpoint. The last study in this slide asks, what is the effect of topiroxostat, a xanthine oxidase inhibitor, and febuxostat on arterial stiffness, uric acid levels, and blood pressure in patients with hyperuricemia and hypertension? And the conclusion was, this trial did not detect any significant effect of topiroxostat and febuxostat on arterial stiffness parameters using the cardio-ankle vascular index. There are some studies that actually favor it. So this was the FREED trial, and it was back in 2019. It asked, does febuxostat versus conventional therapy with lifestyle modification reduce the risk of cerebral, cardiovascular disease, and renal events in patients with hyperuricemia? This is a randomized controlled trial out of Japan. It had a study population of 1,084. The outcome they were looking for was the serum uric acid composite, cardiovascular, and renal outcomes. And the conclusion was febuxostat significantly decreased serum uric acid levels, which is what we expect, and was associated with a reduction of cerebral cardiovascular and renal events. So we get two conflicting responses. And here's another one, another study, which asked what is the incidence of major adverse cardiovascular events, mortality, total and specific cardiovascular events in randomized controlled trials testing xanthine oxidase inhibitor against placebo or no treatment. This was a systematic review and RCTs, and they got 81 different studies. Outcomes are all-cause cardiovascular events, and their conclusion was purine-like xanthine oxidase inhibitors may reduce the incidence of adverse cardiovascular events. However, higher doses of allopurinol of more than 300 milligrams per day may be associated with loss of cardiovascular protection. So what do the guidelines say? So in 2018, and I hope this is not outdated yet, Sam, 2018 EULAR recommendations, they mentioned that risk factors for chronic hyperuricemia should be searched for in every person with gout, especially chronic kidney disease, obesity, medications, excess alcohol, etc. And they also say that systematic assessment for the presence of associated comorbidities in people with gout is recommended, including obesity, renal impairment, hypertension, ischemic heart disease, heart failure, diabetes, and dyslipidemia. What does the 2020 ACR guidelines say? For patients with gout taking febuxostat with a history of cardiovascular or new cardiovascular event, we conditionally recommend switching to an alternate urate-lowering agent if available and consistent with other recommendations in this guideline. So this is where the result of a trial prompted a change in the guideline. And what did APLAR say in 2021? Among patients with asymptomatic hyperuricemia and hypertension, we recommend against urate-lowering treatment to reduce the risk of major cardiovascular events or mortality, cardiovascular and all cause. Why? The level of evidence was very low, and the strength of evidence was strong according to the panel. Now in 2023, EULAR came up with recommendations for cardiovascular risk management in rheumatic and musculoskeletal diseases. And they're basically saying the same thing. Clinicians should be aware of increased cardiovascular risks in patients with rheumatic diseases, including gout. And in the 2023 Hong Kong Society of Rheumatology consensus recommendations for the management of gout, every patient with gout should be systematically screened for associated comorbidities and cardiovascular risk factors. I go back to the 2023 EULAR recommendations, and they recommend thorough assessment for traditional CVR cardiovascular risk factors, blood pressure management, lipid management, and serum uric acid levels targeted below 0.36 millimole per liter or 6 milligram per deciliter. So the management of principles of gout have remained basically steady over the years. And I borrowed this slide from a colleague of mine, Dr. Salido in the Philippines. We treat gout flares. We lower serum uric acid levels. We provide prophylaxis while initiating urate-lowering treatment. We optimize dietary and lifestyle factors as appropriate. Weight loss, limit purine-rich foods, alcoholic and fructose-rich beverages. Total prohibition of purine intake is not recommended since the impact on serum uric acid is limited to less than 1 milligram per deciliter after a very strict diet. And there's a great burden for the patient in maintaining this particular lifestyle. Lifestyle approaches are adjunctive and not replacement for pharmacologic treatment. So are we barking up the wrong tree on the causality of gout or hyperuricemia causing cardiometabolic comorbid conditions? or should we address both? Mendelian randomization studies suggest several traits of the metabolic syndrome are causal to serum urate and gout, adiposity, insulin resistance, and certain lipid components and triglycerides, all cause increased uric acid levels. Our current Western lifestyle trends, and this may not be true in all Asia Pacific countries, we're eating more calories, more portion sizes. We're eating worse, increased red and processed meats, more sugar and fructose, and we're moving less, increased sedentary behavior and decreased exercise. And these all have a direct effect on hyperuricemia and gout. These have also resulted in the obesity epidemic, which has a mediated effect on hyperuricemia and gout. And this also is part of the metabolic syndrome and all the comorbidities mentioned: hypertension, coronary artery disease, kidney disease, and congestive heart failure. And the medicines that we use to treat these conditions also have a mediated effect on hyperuricemia and gout. This is a quote from Yokose: "Healthy lifestyle changes, even on a relatively smaller scale, hold the power and promise to slow down the worsening global burden of gout and improve gout morbidity and comorbidities." So traditional dietary approach of a low purine diet is no longer recommended. There are evidence-based healthy cardiometabolic diets such as the Mediterranean diet and the diet against hypertension diet. These have shown greater sustained weight loss and improvements in cardiometabolic risk. More importantly, the serum urate reduction of 2.1 milligram per deciliter in the Mediterranean diet and 1.29 milligram per deciliter in the DASH diet is noted in those with pronounced hyperuricemia. These are the food pyramids of the two diets that I've mentioned. On your left is the Mediterranean diet, and on your right is the DASH diet. Please note that wine is allowed in moderation, at least in the Mediterranean diet. The red colored letters have increased risk for hyperuricemia, and the green colored letters have a lower risk for hyperuricemia. Daily exercise and weight control is also recommended. What about the effect of sodium glucose transporter 2, SGLT2 inhibitors in serum urate levels in patients with and without diabetes? I decided to bring this up in this talk because of the fact that we're looking at the other side. We treat a metabolic condition and also address the hyperuricemia. So the question for this particular study was, do sodium glucose cotransporter 2 inhibitors reduce serum urate levels in patients with and without diabetes? This was a systematic review and meta-regression of RCTs, and they came up with a number of 43. The outcomes were all cardiovascular death, myocardial infarction, ischemic stroke, but they looked particularly at the uric acid levels, and they concluded that SGLT2 inhibitors are beneficial in reducing serum urate in patients with and without diabetes. SGLT2 inhibitors could therefore contribute to the general treatment of hyperuricemia. A sample of the one of the SGLT2 inhibitors is empagliflozin, and it is this study asked the question, what is the effect of empagliflozin on uric acid levels, anti-gout medication, and gout episodes in this particular trial? This was a randomized controlled trial with 7,000 people, and the composites were all cardiac, and the conclusion was empagliflozin reduced uric acid levels and the composite of gout episodes or prescription of anti-gout medications. So in summary, uric acid may contribute to the cardiovascular diseases and cardiometabolic diseases via impairing endothelial integrity and function, inflammation, and a shared pathology of insulin resistance. The evidence of the causality of gout resulting in cardiovascular disease is still not firmly established, and RCTs and systematic reviews have resulted in conflicting outcomes. The evidence for gout treatment with urate lowering treatment in improving cardiovascular outcomes has showed conflicting results. There is beneficial effect of lifestyle modifications, such as a good diet and physical activity, to lessen the risk of cardiovascular mortality associated with hyperuricemia. SGLT2 inhibitors, which have cardioprotective and cardiometabolic effects, have shown to decrease uric acid levels and lessen gout flares. For my second to the last slide, we are about to start our APLAR gout registry. It's all set. It's a longitudinal prospective cohort study, which will look at the clinical scenario stage from acute gouty arthritis to chronic tophaceous gout in patients with gout. So if you're interested in joining this registry, you're more than welcome. Please just send a message to our APLAR secretariat. So thank you very much. And I'd like to thank my fellows in Makati Medical Center, Dr. Noreen Garcia, Dr. Joseph Lim, and Dr. Eloisa Generoso for helping me with this talk. Thank you very much.
So thank you, Paulo, for the excellent talks. And I know this is a very complicated issue. So please, I know Sam has a question and another one.
Thank you. That was a great talk. I'm interested in your thoughts about colchicine in this context, because most guidelines at the moment suggest that we use colchicine primarily as prophylaxis against acute attacks in people who are establishing themselves on urate lowering therapy. And then we kind of stop it once they've reached a stable target serum urate. But in fact, we know in the non-gout population that there's RCT evidence that colchicine reduces the risk of acute cardiovascular events.
Yes.
So I'm wondering whether we should be tempted to use colchicine, low-dose colchicine, more liberally in this population for its cardiovascular benefits and not just its prevention of acute flares.
Yes, thank you. That's an excellent question. And I actually left it out of this talk because it's a whole different talk. And if you know, if you look at the atherosclerotic plaque, it's really full of inflammatory cells. So it really makes a lot of sense, and it's very tempting to actually, well, I should start with, it should be looked at in and studied better whether colchicine really does have an effect. But it is a very nice and tempting proposition to look into colchicine as a preventive for cardiovascular disease. There was an article on it in the New England Journal of Medicine, I think in 2021. So you might want to look at that. And there was some excitement among the cardiologists, but that's as far as I go. Thank you.
Professor Masood.
Thanks a lot. As usual, you have a nice presentation. What you do often. I have just other way to know something. If you can enlighten us. In my country, and I don't know about the India, the prevalence of gout is very low. And of course, the food habit is not that much different. The fish eating people we are. And then, did you able to check out the differences of the different countries in the Asia Pacific region about the prevalence of the gout and what could be the reasons of having higher prevalence in some of the country?
Well, thank you for the question. I can only hazard a guess. Definitely genetics might play a role in why the prevalence is low in India. But we don't know for sure why. Okay. And I'd also actually, that's where I'm going to segue into the registry. So I hope someone from India gets interested in joining it. And Bangladesh. And we can also look into that. Okay. Thank you. But I don't have an answer to that. Thank you.
Yes. Okay, I'm sorry.
Yes, definitely. So these are, you're managing the cardiometabolic parts, but they might have, from what I know, they might have high uricosuric effects. But it's very interesting that there are drugs that are available and will add to your hypouricemia. So yes, definitely, they're part of the drug armamentarium. Thank you.
Excellent talk. At least
Thank
I
you.
learned more. First thing is, I didn't know that Bangladesh has less gout, although we are neighbors, but we have some, it's a very common gout in India, in spite of a very huge vegetarian population. So that is one. I wanted to ask about the cardiovascular risk with the tophaceous gout, when tophais are there. Any study or any?
You know what? That's okay. I haven't reviewed it, but that's definitely with complicated gout. If you have tophi and whatever happens to tophi infection and all of that. Again, I can't answer that now, but maybe the registry, because those questions are asked in our registry.
So thank you very much. I think in the interest of time, sorry, maybe, yeah.
Presentation like there's of gout.
Okay.
So that's why I'm asking about. I hope the COPCOT results as soon I can compile, and then we'll get the idea. And happy to be with you if you allow to participate in your registry.
Yes,
Thank you very
more
much.
than welcome. Thank you very much.
Yeah, I think the registry will help, I'm sure. So in the interest of time, I think it's better to hand the next section to the next section. So may Professor Soho comes to the stage.
Thank you, Dr. Ronay and Dr. Lorenzo. Now we are moving on to the Myositis SIG Symposium. Today we have with us the moderator, Professor Soho, moderating the session, and the speaker will be Professor Takahisha Gono. Professor Ho, please.
Right. Good evening, seniors and colleagues. I'm Soho from the Chinese University of Hong Kong. So it's my great honor to chair this session, a myositis session of the APLAR midterm symposium. And we actually all know that interstitial lung disease is one of the most important complications of myositis, and probably particularly so in the East Asian countries, because we have probably more anti-MD5 dermatomyositis. And I think this is a very important topic, interstitial lung disease associated with IIM. Right, so tonight is a great honor to have Professor Takahisha Gono to talk to us on this topic. So Dr. Gono is an associate professor of the Department of Allergy and Rheumatology at the Nippon Medical School Graduate School of Medicine. So he obtained an MD from the Yamanashi University and PhD from the Shinshu University Graduate School. So actually in the field of myositis, I think Dr. Gono requires no further introduction. He has published quite extensively, including several landmark papers on MD5 dermatomyositis, as well as lung disease associated with myositis. So without further ado, please welcome Dr. Gono.
Thank you for your introduction, Professor Hosso. Hello, everyone. I'd like to thank the people involved in this symposium for giving me the opportunity to present my lecture. So I'd like to talk about recent advances in idiopathic inflammatory myopathies associated with interstitial lung disease. This is my disclosure. This slide shows the outline for today's my presentation. At first, I will discuss epidemiology and clinical manifestations of myositis associated with interstitial lung disease. Next, what are the prognostic factors? Then, how to treat and stratify patients of myositis associated with interstitial lung disease. After that, how to monitor the disease status of ILD. Finally, I will share my perspective in the future on this field. According to a meta-analysis, the pooled prevalence of ILD, as you can see the figure, the prevalence of ILD is 41%. So the prevalence of ILD is higher in DM and clinically amyosic DM than in PM. The prevalence of ILD depends on geographical regions. For example, 50% in Asia, 26% Europe, and 23% in America. So as you can understand, most of patients have the complication of ILD in myositis. This slide shows clinical manifestations of myositis is highly variable among myositis patients. So IIM subcategorized into 4 groups: DM, IMNM, IBM, and overlap myositis. As you can see, the myositis-specific autoantibodies or myositis-associated autoantibodies are highly related to clinical manifestation of myositis. So, in terms of ILD, MSA, anti-ALS, MD5, and MAA, U1P, COO, PMSL are strongly related of the development of ILD. Let's look at this table, especially anti-ARS, anti-synthesis, and anti-MD5 antibody is strongly related to the development of ILD in myositis. The ILD pattern on computed tomography is highly variable, and let's look at this table. There are a lot of differences in the ILD pattern on CT between anti-synthesis autoantibody positive ILD and anti-MD5 positive ILD. For example, NSIP is higher in anti-ALS positive patients. On the other hand, OP and AIP is higher in anti-MD5 positive ILD. And reticulation, traction bronchiectasis is also higher in anti-ALS positive ILD. So let's look at the upper right figure in anti-synthesis autoantibody positive ILD. The lung regions exist at the base or lower lobes of the lungs along bronchovascular bundle. And reticulation traction bronchiectasis is also found with GGA or consolidation. On the other hand, anti-MD5 antibodies, the lung regions exist at the peripheral area or subpleural area with consolidation on the lower lobes or random GGO are distributed. Next, what is a prognostic factor? Actually, there are many prognostic factors in myositis. So how do you use them? How do we discriminate those prognostic factors? Before we start immunosuppressive induction therapy, we should predict the prognosis in individual patient with myositis ILD. So you can understand many prognostic factors before the determination of the initial treatment. This slide shows conventional prognostic markers. Older age, male, DM, and delay in diagnosis is associated with poor prognosis. In terms of clinical features of ILD, acute subacute home, progressive ILD over 3 months, lower pulmonary function, and corticosteroid resistance ILD are poor prognosis, related to poor prognosis factors. Conventional peripheral blood biomarkers include increased neutrophil lymphocyte ratio, increase of inflammatory markers, and pneumoproteins such as KEL6 and SPD, and presence of anti-MD5, PL7, PL2, or Rho52. So regarding radiological findings of CT, extent of ILD, which occupy over 20%, UIP pattern, or consolidation or GGA pattern, random GGA, those factors are related to anti-MD5 autoantibodies, and higher score composed of consolidation and GGA strongly closely associated with a poor prognosis. Many prognosis factors. Next, I would like to show you experimental prognosis markers. So in clinical immune cells in peripheral blood, increased CD3 negative, CD19 positive cells are independent risk factor for the development of ILD in patients with anti-synthesis. On the other hand, activate CD45 are positive, HAD are positive, CD8 positive T cells with decreased CD56 dim natural killer cells are associated with a rapidly progressive ILD, which is usually anti-MD5 positive or antibody positive. In addition, serum or plasma biomarkers, those biomarkers are related to activated status of immune cells, especially macrophages or monocytes. So the remaining novel biomarkers are reported. So, but it is time-consuming measure those experimental biomarker. It is difficult for physicians to adapt those biomarkers to predict prognosis. So, how do we use them? How do we use prognosis factors? The answer is next. The answer is shown in next slide, partly. Sorry. So this is from JAMI cohort. JAMI cohort is enrolling about 500,000 patients with incident cases and myositis-associated interstitial lung disease. So the aim of the JAMI cohort study is to identify independent prognosis factor. So in this study, the most important, most impact prognosis factor is the presence of anti-MD5. So we focus on biomarkers, including anti-MD5 autoantibodies. So we named MCK model. So we create MCK model focusing on biomarkers. So this model composed of two biomarkers, CRP, KEL6, in addition to the presence or absence of anti-MD5 autoantibodies. We divided patients into 3 groups as the number of risk scores: low, moderate, and high. We separated 3 groups. As you can see, we successfully differentiated survival rates based on the risk factors. So, which is replicated in the different independent cohort. In addition, the similar model is reported from China. This model, FLAIR score. FLAIR score is composed of the presence of RPLD or non-RPLD and HRCT score, the levels of anti-MD5, ferritin, and LDH. Those scores divided patients into 3 groups: 0.24 score, low, 5 to 9 in medium risk, 10 to 13 in high risk group. So as you can see, the survival rate successfully divided each patient. In low risk score, 1 year survival rate 100%. In medium risk group, 80%. In the high risk score, 30%. So independent cohort, this FLAIR model successfully identify, stratify patients in myositis-associated ILD. We show, MCK model, this model, FLAIR model, should be validated to evaluate the applicability to different across world. Next, I'd like to talk about how to treat and stratify patient. Actually, there has been little evidence regarding treatment of myositis ILD because this disease is rarity and diversity and have difficulties in conducting the clinical trial. However, in the past few years, there have been treatment recommendations and past expert opinions provided by academic societies. I will show you them. The first, this is from British Society of Rheumatology. These recommendations divided ILD into two forms of ILD, RP-ILD and chronic ILD. In RP-ILD, calcium inhibitor conjunction with corticosteroid should be considered. In addition, cyclophosphamide or rituximab should be added as early as possible as induction therapy. On the other hand, in chronic ILD, corticosteroid with or without one single DMARD, such as a thiopurine calcium inhibitor or MMF. And in refractory cases, rituximab or cyclophosphamide should be considered. Next, this is expert perspective in refractory myositis associated, which is provided by American College of Rheumatology. So this algorithm divided two groups, moderate ILD and severe ILD. Severe ILD was defined by percent predicted FVC less than 70%, TLCO less than 55%, or HRCT extent over 20%. So in moderate ILD, calcineurin inhibitor or MM should be considered in conjunction with corticosteroid. If the treatment response is poor, so we should consider adding rituximab or cyclophosphamide. In severe ILD, at first, cyclophosphamide or rituximab should be considered. This is from Spanish group. This algorithm is specific for anti-MD5 positive associated RP-ILD. At first, the combination therapy with glucocorticoid plus calcium inhibitor or triple combination therapy, including cyclophosphamide. If calcium inhibitor is contraindicated, it should be avoided. Instead of calcium inhibitor, rituximab or MMF should be considered. If the treatment response is poor, so adding other immunosuppressants such as tofacitinib, or we should consider plasmapheresis or ECMO to prepare for consultation of lung transplantation. So lastly, this is from Japanese College of Rheumatology and Japanese Respiratory Society. This algorithm was composed by disease behavior, acute subacute home or chronic progressive and chronic non-progressive, and MSA profile, MD5 positive, anti-ALS positive, double negative. In addition, physician can consider other prognostic factors as shown in this slide. Additionally, recently, there are several studies which conduct identification of homogeneous group in myositis ILD because we need to conduct personal medicine for individual patients in myositis associated ILD. So from JAMI cohort, we can identify 6 groups separately. So group 1, group 2 is anti-MD5 negative, but had no requirement of oxygen. Those groups are relatively, prognosis is relatively good. On the other hand, cluster 5, 6, all patients had require supplements oxygen, regardless of MSA profile. Those patients' prognosis is worse. So in the middle group, group 3, group 4, all patients have anti-MD5 positive. Those patients are relatively worse, prognosis worse. So unfortunately, we had to identify group which the better response to the initial triple combination therapy than the other therapy. So lastly, I'd like to talk about how to monitor the disease status of ILD. So how to monitor status of ILD? So physicians should comprehensively assess the ILD based on respiratory symptom, SpO2, physical examination, pulmonary function testing, lung imaging, and biomarkers. Actually, some biomarkers play some important role in the evaluation of disease activity, the severity. KL6 is a specific of the lungs. KL6, sometimes increase of KL6 is happen in other disease, but KL6 increase associated with antisense or antibody. Anti-MD5 is also correlated with the disease activity, so it's very useful to monitor those biomarkers. So this slide shows the treatment goal based on the disease behavior. We should set the treatment goal in individual patients. For example, acute, subacute home ILD, the treatment goal is to remission or life-saving. And chronic ILD, so the goal is to prevent acute exacerbation or recurrence and maintain or stabilize the ILD. Finally, I'd like to share my further perspective. So at first, I define and evaluate accuracy of risk stratification model for mortality. Next, I identify pathology more clearly and biomarkers measurable in daily practice. Then we need to develop novel target therapy, especially for respiratory cases, including anti-MD5 or anti-MD5 antibody, ILD, despite triple combination therapy, or anti-ARS positive ILD with recurrence or progression of ILD. So finally, we need to elucidate methods for monitoring disease activity and progression accurately. So we need to collaborate research investigator over the world to solve those issues. Thank you for your attention.
Thank you, Dr. Gono, for the very insightful and comprehensive talk. So now the floor is open for questions. Dr. Yi, please.
So thank you very much for your talk. It's very enlightening and innovative. So I would like to know the role of the antifibrotic therapy on top of the immunosuppressive therapy in this regard in the interstitial lung disease.
It's very important question. Actually, I don't know have precise answer, but personally, in anti-ARS ILD, in some cases, the progression of fibrosis is happen. So I need antifibrotic such as nintedanib with conjunction of immunosuppressive therapy, including cyclophosphamide or calcium inhibitor. So some cases have progression of ILD, fibrosis ILD, despite the immunotherapy, so immunosuppressive therapy. So, but I don't know which patients should be treated with antifibrotic therapy. Yeah, sorry.
Yes, please.
Since this is one disease where biopsy is available, so what are the papers which is suggesting about other genetic markers or some other studies on the histopathology? Because this is one disease where we definitely have a histopathology available. So because we are working more on the MDA5 and other antibodies. What about the histopathological and any prognostic markers on histopathology?
Thank you for your nice suggestions. So I haven't investigated genetic backgrounds, but as you say, so we should assess comprehensive assessment, including genetic, several biomarker, CT imaging. So yeah, in the future, we need to elucidate the EDR prediction model. Yeah.
Yes, please.
So there are multi phases of your dermatomyositis. Of course, it is a little away from your own talk. So we do have the skin involvement and that of the some change in the muscles, calcifications and others. So while choosing your drugs, do you find the selection of azathioprine or the cyclophosphamide should be a change or over or swap to each other to covering all of this?
Sorry, it's very difficult question for me. So yeah, but it's very important. In this session, we focus on just lung disease, but as I say, skin and arthritis, yes, we need to evaluate all organs. Yes, yes, thank you.
Right. Oh, okay. So I think there are some questions online. So this question is also on nintedanib. So I think it has been addressed. Right. Oh, so I think this is also a very important question. So is on the role of tofacitinib or IVIG once UIP has set in. Right, so is about the role of JAK inhibitors as well as IVIG in patients with ILD associated with myositis. What was your comments?
Is this question about the potential of JAK inhibitor and IVIG for myositis ILD?
Yep.
This is also difficult to answer question. But personally, JAK inhibitor may be useful for refractory cases. For example, we initially conduct triple combination therapy, but some patients have poor response. So JAK inhibitor may be saving time to have a good response from other immunosuppressive. IVIG is, I'm not sure the potential of IVIG. IVIG is inhibiting the production of cytokine, the neutralizing of several autoantibody. But IVIG, the efficacy of IVIG is potentially, yes, I don't know.
Okay, so if there's no more questions, so we'll hand over to the next session. Thank you again. Thank you, Dr. Gono. Thank you.
Thank you.
Thank you, Professor Ho, and thank you, Professor Gono. Now we're going to move on to the next SIG session, which is the scleroderma SIG. Today we have the privilege of having Professor Yasushi Kawaguchi chairing the session. And speaking with us today on the management of pulmonary hypertension in systemic sclerosis is none other than Professor Hidakita Yasuka. Professor Kawaguchi, please.
Okay. Hi, good evening. So a little bit 10 minutes or 12 minutes late. So I would like to start this session. This session topics is systemic sclerosis, scleroderma, especially pulmonary arterial hypertension. Today's speaker is a very, very ideal speaker. Professor Yasuoka is one of the most famous professor of the field of systemic sclerosis in Japan. He has many publications of basic research and clinical research in scleroderma. A little bit, I'd like to introduce him. Professor Yasuoka is a medical doctor with an MD degree from Keio University and also PhD degree from Keio University School of Medicine in Tokyo, Japan. And he moved to the University of Pittsburgh Medical School, and he studied many fields of systemic sclerosis. Dr. Professor Thomas Metzger. And He has been certified by several boards, including the Japanese Society of Internal Medicine and Japan College of Rheumatology. He's a member of several professional and scientific societies. And also he has received several honors and awards for his systemic sclerosis research. Professor Yasuoka, unfortunately, he is now is not here and online. Are you ready to speak, Professor Yasuoka?
Hello, Dr. Kawaguchi.
Okay.
My name is Hidekata Yasuoka, so I'm online. So can I start?
Okay.
Start.
Please start.
Okay, so I will share my slide. So let me start. Let me upload my slide. Okay.
Okay. Slide is not working.
No, it should. I'm sorry. Wait for a moment. Okay, so can I start?
Slide is not working. Still, huh?
No.
Okay.
Okay.
Okay. Okay.
So thank you very much, Professor Kawaguchi, and thank you very much for organizers for having the chance. And my name is Hidekata Yasuoka from Fujita Health University, Aichi, Japan. I'm going to talk about management of pulmonary hypertension and systemic sclerosis. So this is my COI. So I'm going to talk about pulmonary artery hypertension, PAH. The pulmonary artery hypertension is caused by the narrowing of the pulmonary artery or arterioles and upregulation of the pulmonary artery pressure, and which results in the right heart failure. Usually, mean pulmonary artery pressure normally 14 plus 3 millimeter mercury, and threshold is 20 millimeter mercury, as Kavak reported. So the definition of pulmonary artery hypertension is mean pulmonary artery pressure was above 25 millimeter mercury. Pulmonary artery wedge pressure is below 15 millimeter mercury, and PVR, pulmonary vascular resistance, was above 3 units. This is a new definition of pulmonary artery hypertension, and mean pulmonary artery pressure was decreased to 20, and PVR was decreased to 2 units, suggesting that we should detect PAH much more earlier than expected. Anyway, I also talk about connective tissue disease, Kogenbyo in Japanese. Connective tissue have three characteristics. And one is rheumatic disorders as clinical concept, connective tissue disorders as pathologic concept, autoimmune disorders as immunologic concept. This is general disease course of connective tissue disease, which is started from injury and trigger, and usually infiltration of immune cell will be seen. And then inflammation will induce damage and repair. And if wound healing is physiologic, it's going to the regeneration. But it's going to the pathologic, remodeling and fibrosis will occur. Connective tissue disease will go this way and then accumulates remodeling and fibrosis, which results in the organ damage and poor prognosis. Anyway, I'm going to talk about CDD-PH today because CDD-PH is thought to be a population who have the worst prognosis among all PH categories. This is the clinical classification of pulmonary hypertension reported in the 2022 ESCRS guideline. Classification is not changed so far, and classified into 5 cases: Group 1, pulmonary artery hypertension, pulmonary hypertension associated with left heart disease, pulmonary hypertension associated with lung disease, And pulmonary hypertension associated with pulmonary arterial obstruction and pulmonary hypertension with unclear multifactorial mechanism. Connective CTD-PAH is classified into 1.4.1 here. This is a background disease of connective tissue disease in CTD-PAH. This is a kind of single-center study in Japan. And as this slide shows, MCTD, mixed connective tissue disease, SLD, systemic lupus erythematosus, and systemic sclerosis is the major disease in Japan. But when we go to other Asian countries like China, Taiwan, and Korea, SLE is a major disease. On the other hand, when we go to Europe, systemic sclerosis is a major disease. So there might be some of the ethnic factors for the onset of the CTD-PAH. So let's go to each disease, and this is SLE. The SLE is, as you all know, as a prototype of systemic autoimmune disease. SLE should have the various organ involvement shown here, but it's not. It doesn't include the pulmonary hypertension, because pulmonary arterial prevalence of pulmonary arterial hypertension is relatively low in SLE, like 3%. But this prevalence is relatively high compared with idiopathic pulmonary arterial hypertension. When we look at the histological finding of pulmonary artery, blue slides show the SLE. SLE doesn't have the pulmonary fibrosis or pulmonary vascular change, but it has the immune cell infiltration, suggesting that SLE-PAH is associated with disease activity of SLE. So usually when we treat the SLE-PAH and other non-SSC-PAH, we usually use immunosuppressant, including high-dose glucocorticoid and cyclophosphamide. The aim of the treatment is normalization of the hemodynamics. Usually, pH drug, including PD5 inhibitors, is combined with immunosuppressant. So let's go to systemic sclerosis. Systemic sclerosis, as you all know, has the triad: fibrosis of skin and organs, microvascular injury, and autoantibody production. But we have to manage the fibrosis or the modeling, but we do not have so much good treatment for this kind of management. Systemic sclerosis also have the various kinds of organ involvement, including the cardiopulmonary involvement, gastrointestinal involvement, microvascular involvement, and myoskeletal involvement. These organ involvement can determine the prognosis in SSC. And for example, when we look at the frequency of death, PAH and ILD is the most frequent cause of death in scleroderma recently. And also, when we look at the mortality, patients with PAH have a very poor prognosis like this. 2 years survival is around 40% in natural cause. When we look at the histology of the scleroderma in red, they show the pulmonary fibrosis and pulmonary vascular change here. There's not so much infiltration in immune cells, suggesting if fibrosis remodeling is a major pathogenesis of scleroderma. So we have to manage the fibrosis or remodeling, but there is no good treatment so far. And also in scleroderma, complex abnormalities in pulmonary circulation can be observed. Many patients have not only the pulmonary artery involvement, but also the lung and heart involvement, and also the pulmonary vein involvement. So not only pulmonary arteries, but also other regions can be involved. So evaluation of other organ involvement are important. So based on these backgrounds, the prognosis of SSC PAH is much poorer than non-SSC PAH. So for the improvement of prognosis of the SSC PAH, we have to have the development of novel treatment approach and early diagnosis, in addition to community awareness and education. However, we don't have not so much good treatment so far. We need early diagnosis and screening for the improvement of the prognosis. This is one of the good example of the showing the significance of active screening in SSC-PAH. So its systematic detection program means the screening in asymptomatic patients, and routine clinical practice means follow up the patients in the symptomatic patients. When we compare these two groups, the prognosis is quite better in systematic detection program, suggesting that active screening helps improvement in prognosis in SSC-PAH. So we have to think about how do we grab earlier cases. So there is two approaches, and screening aggressively and focusing on high-risk group, or developing novel screening methods. So let's go to the first one, focusing on high-risk group. So there is some reports mentioning about the high-risk group, including patients, SSC patients with limited cutaneous scleroderma, anti-centromere antibody, duration more than 10 years, and telangiectasia. In some reports, pulmonary function test results are also combined in here. So these are very high risk group, so we can detect PAH patient effectively using this kind of high risk group. But systemic sclerosis itself is a high risk group for pulmonary arterial hypertension. So recent guideline mentioned that in patients with CTD-PAH with overlap feature of SSC, an annual evaluation of the risk of PAH may be considered. Borderline MPAP cases are also another risk factors. And borderline MPAP is formally defined in 20 to 20 MPAP between 20 to 25. This population can develop pulmonary hypertension much more higher compared to normal MPAP cases. If we follow up more than 5 years, more than 30% of patients will develop the manifest PAH, whose hazard ratio was 3.7. But when we interpret the borderline MPAP cases, we have to be careful about that. This is a result from Farrell's registry, and this includes the 28 case with borderline MPAP cases. But more than half of the cases had significant ILD defined by the pulmonary function test and high resolution CT scan. So let's go to the developing the normal screening methods. And first one is combination of several indicators to increase sensitivity. So this is the detect algorithm, one of the good example called detect algorithm, which is the evidence-based screening algorithm for scleroderma PAH, which is consisted by the 6 non-echo variables as step 1. And if we have the high score, and then we will go to step 2. And then if we have a very high score, we will go to the right heart cell test to examine and to confirm the diagnosis. This algorithm was tested in SSC patient with over 18 years old, disease duration more than 3 years, and person DSCO was less than 60%. Prevalence of PAH in this population is around 90%, which is higher than the normal population. And the aim of DETECT study is not to miss the PAH cases and standardization of modalities and the selection for right heart catheter test. So this DETECT algorithm was very good because they only missed the 4% of PAH cases, and overall sensitivity was 96%. So this algorithm are good not missing the PAH cases. However, the running cost is the issue, because once we use the DETECT algorithm, we need more than 200 euro per analysis. But when we look at the other analysis, it's only half of them. Also, DETECT algorithm is only examined by cross-sectional study, so we do not know how often we have to do that or when to do that. Also, patients identified the DETECT algorithm are not mild, but almost of the cases identified by DETECT algorithm was asymptomatic or very mild. But when we observe the patients after 1 year, around half of the patients have a progression, 40% have the exacerbation of functional class, 30% admitted to the hospital, and 20% have needs combination therapy, and 10% was died. So again, not all cases identified with DETECT are not mild. So let's go to the another screening approach called induced potential PAH by the artificial rhodium. So in this slide, as I already told you about new definition of the pulmonary hypertension, here is exercise pulmonary hypertension, and this means exercise cardiac echo. And this is reappeared again in the new guideline again. So exercise is one of the good options to do that. And here is the interesting data, and using the 76 sclerodermal case, and the right heart catheter test was tested in that rest and during the exercise. So in 76 patients, 22 patients had manifest PAH, but 15% had a PAH and 3 with ILD, 4 with chronic heart disease. Also, 21 patients with exercise PAH patients, 2 patients has chronic heart disease. So this means patients with not all precapillary PAH on exercise patients do not go to resting PAH. So natural history is not so clear by the stress echocardiography itself. So we have to carefully interpret the results of stress echocardiography. So based on these findings, here is a new recommendation in 2022 ESC-ERS guideline. I do not touch the detail here, so please check the guideline and to lead with. So let's go to the treatment. As you all know, there is a 3 classes of pH drug, enzyme pathway drug, nitric oxide, and prostaglandin I2 pathway, 3 pathways here. So there is a trend of the change of the treatment of sequence, and we usually use the combination therapy of these 3 classes of drugs. Formerly, we used the add-on therapy, in other words, the sequential combination therapy. But recent trend is upfront combination. It is because monotherapy did not improve the prognosis of SSC-PAH compared to IPAH. This is a good example of the evidence of upfront combination therapy called AMBITION study. So AMBITION study was examining the combination of the ERA and the PD-5 inhibitor compared with the improved monotherapy. and prognosis is quite better in combination therapy. And that trend was also seen in CTD-PAH, SSPA-PAH by the forest plot. So based on these results, most of the patients were treated with combination therapy recently, based on the risk stratification. However, there is some of the patients should go to the initial monotherapy. So what kind of patients go to the initial monotherapy? So this is a list of using a monotherapy. And when we look at this list, mild patients are included, like CCB responders or well controlled with monotherapy for 5 to 10 years, or very mild patients. But in this list, case more than 75-year-old having a risk of HFpEF, and case suspected to have PVOD are included. These characteristics are matched with the characteristic of SSC-PAH, suggesting that we have to be careful about the screening of the patient with scleroderma PAH, and whether they might have the ILD or a cardiac involvement. We need this screening. Also, the establishment of the follow-up system is also quite important. For early detection, general practitioner and non-PA center can do that. But for the specialized medical service, PA center must do it. And then quick referral or collaboration is very important for the quick response, quick treatment for the patients. Also in the guidelines for the specialized medical services, policies to evaluate the risk of having PAH should be considered in hospital managing the patient with SSC. So we have a lot of requirement, especially in the specialized medical services and PA centers. So thank you very much for attention. This is my summary slide. So thank you.
Okay, thank you very much, Professor Yasuoka. So talk is open. So comment or questions in the audience. Oh, yes.
Does that does the treatment of PH differs in the lupus and MCTD versus systemic sclerosis? I couldn't hear properly. The difference in the treatment once a pulmonary hypertension occurs in lupus and MCTD, it differs from the classical systemic sclerosis.
I'm sorry, you mean the difference of the treatment?
Treatment part.
Treatment in SLE and compared with scleroderma.
Yeah, you showed high dose steroid, cyclophosphamide. What about others like you have drugs like PD4 inhibitors and other drugs?
Thank you very much. It's a very good question. And in scleroderma, we do not use any immunosuppressant for the treatment. We usually use the vasodilators, pulmonary PAH drugs for the treatment for scleroderma. So we usually use ERA or PD5 inhibitors or prostanoid for that. However, when we talk about SLE or MCTD, they have the immunological activity. So we usually use immunosuppressant at first. So we usually start with prednisone plus cyclophosphamide, but most of the case need to add the PAH drugs, including ERA, PDA5, and prostanoid. So that depends on the case. Thank you very much.
Okay.
Thank you very much, Yoshioka, for the nice presentation. can
Thank
you
you.
please enlighten us with is there any clinical predictors in systemic sclerosis that can guide to select your treatment modalities or the drugs? Am I clear? Clinical
Thank you very
predictors,
much.
clinical
Yes,
predictors
yes.
for the selection of drugs.
Thank you. I can hear you. And thank you very much. I think there is no report about the prediction of the treatment response. But when we look at the patients with SLE or MCTD, simultaneous onset of PAH and basic disease, I mean like SLE or MCTD, is a good good sign for the response for the immunosuppressive treatment. But when we talk about scleroderma and the response to the vasodilators, we do not have so much good markers for that. Thank you.
Okay, thank you. Several questions from the on the net. Professor Yasuoka, one question is how do we measure stress pH? I think it's a exercise of mean PAP or something like that. Do you have some protocol of intensity and duration? Exercise, light heart catheterization.
Thank you very much. I showed the results of the other people's paper, but we also use the echocardiography, but we have the detailed protocol, so it might be a little bit difficult for me to explain in detail. So if you need some of the detailed information, I will send you the information later. Is that okay?
Okay. And the next question is, what's your experience in treating with the upload combination is three combination drugs, including the Selexpag? Do you have any experience?
Yes, but we don't have the case with upfront three drugs combination, but as sequential combination, yes. But in some case, we need the triple combination therapy to treat with. But we don't have not so much cases, so we cannot say this is effective or not. I'm sorry about that.
Okay, and last question is, any difference in management of ILD-associated pH as opposed to ILD-SSC only? Well, I think ILD-associated pH compared to the genuine PAH, I think. So
yes.
group 1 and group 3. I think
yes, Group 1 is very easy because it's only the PAH, so we can use the PAH drugs for the treatment. But if the patient is with interstitial lung disease, if we use the PAH drugs, that might induce the some kind of bypass of the so it might be worse. I mean, worsening by the treatment with pH drugs. So we have to be careful to use the pH drugs in case of having the ILD. So
okay,
that's a difficult case. Thank you.
Okay, thank you very much. It's time to close this session. So thank you very much.
Thank
you, Professor Dawaguchi, and thank you, Professor Yasuoka, for the sharing. Now we're going to move on to the next session, presented by the Social Commitment and Patient Outreach SIG. Today we are honored to have Prof. Nigat Ahmad to be our moderator. And speaking with us today, we have someone from UK, Professor Anthony Wolf, who will be speaking to us on the global burden of RMDs, how should the rheumatology community respond? Prof. Ahmad, please.
Konbanwa to my Japanese friends. Welcome. It's a great pleasure and honor for me to introduce Professor Wolf here. And I personally feel he does not need any introduction, but he's such a great name and has done so much work on global burden of rheumatic diseases that it doesn't need to be, to be mentioned here. But let me tell you that he's co-chair of Global Alliance of Musculoskeletal Health. He's director, Bone and Joint Research Group at Royal Convent Hospital, Truro, UK. He is a consultant rheumatologist at Royal Convent Hospital, UK, and he has held honorary chairs in rheumatology at the University of Extra-Medical School in Plymouth University, Pennsylvania School of Medicine. He's visiting professor in MSK, Faculty of Medicine, London University, and he was the clinical director, National Institute of Health, Clinical Research, Southwest Pennsylvania, till 2019. His work, which I'm so proud of, actually, knowing it later in my years, focuses on influencing policy and practices nationally and internationally through evidence-based advocacy. He leads the Bone and Joint Monitor Project, which is a global health need assessment of musculoskeletal conditions that identifies the burden through the global burden of disease study, which everybody should know, and has identified solutions through pan-European and global collaborative projects. He has almost, I should say, published like over 200 review papers, 81 editorials and reviews, 61 chapters, and which were written or edited 28 books, book reports. His work is particularly on disability, aging, and non-communicable diseases, which now top the list of musculoskeletal, top the list of disabilities due to different diseases. And it is my honor and pleasure to welcome you on behalf of our SIG, which is new and is doing its best to reach out to the community. Professor Wolf, welcome.
So thank you very much, and I hope you can hear me all right.
Yes, we can hear you.
Okay. So thank you very much for that introduction, and to the SIG for inviting me to speak at this symposium. And I speak on behalf of the SIG, but also on behalf of the Global Alliance of Musculoskeletal Health and all the work we're doing to try and make RMDs a priority in the healthcare systems around the globe. So we know that musculoskeletal health is central to well-being and healthy independent lives, that conditions affecting it are common in all countries and cultures, and it's an enormous cause of disability with major costs on health and social care. Also, we know there's many effective ways of preventing and treating these conditions, and we've heard in previous presentations all the enormous advances that have been made over the last few decades. But the challenge is there's a lack of policies and priorities for musculoskeletal conditions, and therefore there's not the investment and resources to actually implement all these interventions. And this results in enormous unmet need and avoidable disability. So when myself and colleagues formed the Bone and Joint Decade, which transitioned into the Global Alliance for Musculoskeletal Health, our key aim was how do we ensure that musculoskeletal health is among the leading health concerns in the minds and actions of opinion formers and policymakers throughout the world, which would then result in resources to do all those enormous advances that we've been hearing about. So most of us work at the micro level in our clinics or in the meso level in research and developing services in our localities, but it's at the macro level where the policies and resources are made and resources allocated. And this is what I've been focusing on over the last few years. So what we need to do is see how we can strengthen health systems to actually deliver what we want. And that is improved health services with improved outcomes for people with or at risk of these conditions. So when one's looking at how to change policies at a global level, we have to define what the problem is from our perspective. What are the issues? What can we do about them? We then have to understand why it should matter to the policymaker, because otherwise it's a very hard sell. And then we have to build a coalition to drive change forward. And this is the approach we've been taking. So first is, what is the problem? So how do we justify and facilitate action? So we must have a common understanding and narrative around what RMDs, musculoskeletal conditions, are. And that's a bit of a challenge. But then we have to provide the evidence of burden, what can be achieved, and argue the case for change. So firstly, we've been bringing together all RMDs, or we often call them musculoskeletal conditions, whether it be joint diseases, connective tissue diseases, musculoskeletal pain, such as back pain or more widespread pain, osteoporosis and fragility fractures, but also trauma, because from the individual's point of view, the cause is not so relevant. It's the disability that the problem causes, which is important to them. Then we need to look at the impact it has on people, both at the individual human level, quality of life, the support they need from their families and friends, but then at the economic level, because although policymakers are obviously concerned about individuals and are caring, when it comes to it, it's about the financial aspects, which are the key thing. And this is where it's around healthcare costs, social support, and impact on work, which is very important. So one way that the burden of diseases has been looked at by policymakers is looking at what's called population health. So this is looking at the health of everyone, and it's a way of trying to balance the importance of different diseases who are all competing for limited resources. It's trying to create a common currency to describe health and the impact of conditions. And the key measures are what are called disability adjusted life years, which is a composite of years of life lost prematurely and years lived in disability. So it's a measure of death and disability. Therefore, conditions which cause premature death obviously score very highly in this sort of currency which is used. But so if we look at both death and disability in this scale of DALYs, then despite having a low mortality associated with them, musculoskeletal disorders come number 6 in the ranking. And not surprisingly, at the top are cardiovascular diseases and neoplasms, as well as maternal and neonatal, because this is global data. If we again look in another way at the total burden of disease globally, you can see if we're looking at just disability, then musculoskeletal conditions are the greatest cause, and then mental health issues. And again, if we're looking at disability, leaving out mortality, premature mortality, globally, then the conditions right at the top is low back pain, other musculoskeletal conditions, neck pain, and osteoarthritis. This does not mean conditions like we've been hearing of, systemic diseases, rheumatoid arthritis, aren't having an impact, but it's because the numbers of people affected are far less, it doesn't get into this global ranking. We sometimes think the burden is largely for high-income countries, but actually, if we look at the data at different economic regions across the world, you can see that musculoskeletal conditions have a high impact. And the only reason they have a lower impact in low-income countries, which are largely low and middle-income countries, developing countries, that is because they have a high burden of infectious diseases and childhood diseases. And this is looking at all diseases in proportion. So now if we look at Asia, again, you can see musculoskeletal conditions are by far the greatest cause of disability. But I would like you to name a country in Asia that has prioritized musculoskeletal health, as one of their top health concerns. Again, if we look at the different conditions that are having great impact in Asia, it's again low back pain, other musculoskeletal conditions. Other includes aches and pains, but also connective tissues and other things which are not picked up in more disease-specific surveys. And in general, we don't have enough data telling us what is the impact of those very less common but high impactful conditions. But we've captured it under this other category, then neck pain, and then osteoarthritis. The other myth we have is that musculoskeletal conditions are something of old age. But you can see here, this is looking at age from birth to over 95. You can see that musculoskeletal health conditions have a major impact at all adult ages. And actually, mental health issues get less as people get older. So we have to stress that this is not something which affects just old people, but it's the whole population. When we look at the individual diseases, this is in Asia, again, looking at disability against age, you can see, you can see that again, it's other musculoskeletal conditions, gout, neck pain, back pain, osteoarthritis, and rheumatoid arthritis all contribute to MSK being the greatest cause. I said at the very beginning that there's a lot of unmet need leading to avoidable disability, and this is WHO data estimating the amount of disability out there which could be effectively reduced by rehabilitation. And you can see globally and in Asia, either the Southeast Asia region or the Western Pacific region, MSK is the biggest cause of preventable, treatable disability. So really a lot of data justifying action. Another driver for action now is that the burden is increasing because of our lifestyles and the aging and growing population. We do not live healthily. In many countries, people are still going into the cities, reducing the amount of physical activity they do, and with sedentary and urban behavior, more injuries, road traffic injuries, more obesity, poorer diets, sedentary behavior with less physical activity, and all conditions go up, particularly musculoskeletal conditions. The other thing is the aging of the population. And you can see here in Asia, the predictions of the growth in the over 65 population. And as I've shown, that this is where you get high impact. So that is going to be increasing the amount of osteoarthritis, back pain, and the cumulative effect of rheumatoid arthritis. This is, again, data showing the trend over the last 30 years, where you can see the burden has been steadily increasing of the non-communicable diseases, but particularly MSK, whereas the impact of nutritional and infectious diseases has been relatively flat. And this is Asian data as well. So we did manage to get recognition with the increasing number of older people and changes in lifestyle. Action is needed now, but sadly it was in 1999, stated by Kofi Annan at the launch of the Bone and Joint Decade, and we still haven't quite managed to get those action to happen, but things are beginning to move. So the next step is we have to show that we have solutions. It's no good just complaining without coming up with what do we want. So we do have interventions for primary prevention, a healthy bone and joint, healthy lifestyle with more physical activity, better diets, less obesity, less injuries. We do have ways to treat the at-risk population or those with the early onset of the condition through identifying high-risk individuals, screening tests, recognizing the first fracture to know that that person is vulnerable to a second fracture, for example. And we do have very effective treatments that we've just been hearing of. And there is good rehabilitation interventions which can reduce the burden. So there's no lack of things out there. There are many guidelines, recommendations of how those interventions can be used, but it's how do we actually get those to be implemented. So this is where we have to go to the next step of identifying why it matters to the policymaker you're talking to. if any of you have met a policymaker, a politician, trying to get into the conversation something you want, which is not on their agenda, is extremely hard. So we have to highlight the issues about the aging of the population, unhealthy lifestyles, accumulating multimorbidities, COVID and long COVID, inequality in access to healthcare. These are the current challenges to health systems that we have to work out how do we get into those debates. Because it's generally recognized that the population is living longer but not healthier. So how can we positively contribute to that? But also we have to recognize the economic climate, where there's a need to control health and social care costs around the globe, and the need to extend working lives in many countries. And this just shows the financial pressure on governments, on policymakers, showing the exponential increase in healthcare costs. And in addition to this, with aging populations, there's the social care costs that we have to consider. So there are challenges out there. So we have to show how we can contribute to making people healthier and more independent and able to stay in work for longer and be individually self-sufficient. We also have to fit into other agendas, global agendas, and there are the Sustainable Development Goals, and health comes under number 3, and that's around universal health coverage. So how do we make sure that we're involved in the debate around universal health coverage, which means prevention, treatment, palliation, and rehabilitation? So how do we make sure we're on that agenda? So we have to position our argument so it resonates with those sorts of things that they're thinking around, and highlight that musculoskeletal conditions are chronic, have a major impact on function, get away from the concept that they're an inevitable part of aging, and get people to recognize that things can be done. And also we have to make sure that we're not only targeting the ministries of health, but also the ministries of finance, and emphasize that investing in musculoskeletal health is a way of improving people's independence and productivity, because sadly, that's the focus when it comes to policymakers. So we have the evidence, we know why it needs to be relevant to the policymakers, but then we all have to sing off the same sheet and promote our action together. So we have to build a coalition. And what we've done through the Global Alliance is try to bring together like-minded individuals and organizations with shared vision and mission who want to make a change, and also recruit allies beyond the usual suspects who will help support our arguments. So, for example, we have to work with the International Labour Organization, we have to work with other disease areas because of the between musculoskeletal health and other conditions. We've just been hearing about cardiovascular risk and gout, so we have to look at those cases as well. For example, when I was working with WHO to get musculoskeletal health into the European strategy for non-communicable diseases, my best ally were the respiratory physicians who recognized that they couldn't rehabilitate their patients because they had bad knees and limited mobility. So you have to come together as a coalition, and that's really the purpose of the Global Alliance, a tool to enable us to work in a coordinated way and bring together all the stakeholders, as I said, who have this common wish to shift the agenda. So then we have to know more precisely what it is we want to happen. What would the ideal health system look like to respond to musculoskeletal challenges? So we did a large project over the last few years, which several of you have participated in, and I know that Andrew Briggs has spoken to this meeting in the past about. So we really were trying to see what's out there, can we get a blueprint together? So we did a review of what's in existence, we asked individuals what they thought, and we did a Delphi to come to some consensus. And we also looked specifically at what was needed in low and middle income countries to make sure it was not Western centric. And we came up with 8 pillars. You can look this up, I'm not going to go through the detail, but 8 pillars of what is needed to drive things forward. As I said, we did a further analysis of what we had from low and middle income countries to make sure it was relevant to them. And the key things which came out of that was that we need to engage and educate communities and governments, not just ourselves, but the outside community, so they better understand musculoskeletal health and its impact and value it. So there's more people campaigning for a priority. We have to make sure that musculoskeletal health is integrated into all policies. So again, we have to watch out what's going on in the cardiovascular world, the mental health world, where it could be relevant to promote the importance of mobility, pain-free mobility, and good musculoskeletal health. We need to build capacity because we do not have an adequate workforce. And I know that's a project of this SIG. We need to make sure there's financing, and we need data. Data doesn't not only show the burden, but also data to monitor how effective interventions are or not, so that we can refine our approach to prevention and control. So one of the key things is a workforce, and we need a structured workforce. We obviously need specialists with high skills, but there will always be limited accessibility to that level. So we also need at the bottom the health community who have a better understanding of musculoskeletal health and basic treatment and when to triage up the system. So we have to approach all components to make sure that people get the right care at the right time that is going to give them the best outcomes at the right cost. So in summary, health system strengthening is essential. And at the moment, national responses are very variable, and there's only a few countries where there are clear strategies for musculoskeletal health. But we have got this co-designed blueprint of what is needed. It's been translated into multiple languages, so it can be used across the globe. And we're working with WHO to see how we can drive this forward. So GMUSC is in the process of establishing official relations with the WHO, so that there's a voice for all of you as stakeholders. We're working for a World Health Assembly resolution that calls for action by the WHO and member states to deal with the large and growing burden of musculoskeletal conditions on individuals and society in all countries. So to explain to you, the WHO is an organization that does what it is instructed by the World Health Assembly. And the World Health Assembly mirrors the United Nations. It has membership from all countries who are members of the UN. And they have a vote. So we need to get our national politicians to say they want the WHO to be proactive around musculoskeletal health. And we are also working directly with WHO to try and support them and try and make sure that at that level, MSK health is embedded in all activities, policies, and priorities. So how can you contribute? So we hope we've created the opportunity by highlighting the burden, by identifying interventions which work, and also what is needed at the health system level to respond to the burden. So we need everyone to be advocating for this and using political contacts at the local level, the regional level, the national level. So please use these recommendations. They can be adapted to your local environment, but because they are a framework. It's not a black and white, this is how to do it. It's a framework. And crucial, gain national political support for global action so that we can get a World Health Assembly a resolution saying that musculoskeletal health is important. Actions must be done for prevention and also treatment, because otherwise we will not get access to all these up-and-coming expensive therapies we've been hearing about universally available. And we have to work as a community to drive this forward. Thank you.
Thank you so much, Professor Wolf, for an excellent talk and the advice as to how to improve the musculoskeletal health globally. The forum is open to questions. So does anybody have any questions? I was looking at the Q&A box because it was also well explained by you, Professor Wolf. Can I ask you a question?
Yes.
Yeah. So, the 8 pillars which you just mentioned, I think they're fantastic. But what I, as a rheumatologist in a developing country, which is based, in Lahore in Pakistan, we can do things at our own level, which is the micro level, but macro level, but the top level, it's so difficult to move them that it doesn't seem to happen. And it gets you frustrated because, the policymakers, as you said, they need their mindset to be changed. That and so rightly, the work which you've all done, Andrew, and of course under your guidance, that it's evidence-based, that musculoskeletal health with economies which are going down with the COVID, long COVID, climate change, and aging population, this don't seem to, realize that this is very important, especially for all nations, but especially for low income and middle income countries as well. So I find that the challenge, which is very difficult. So we found a solution for ourselves. We said, till we can move them.
So I entirely agree with you. And having started this journey a long time ago, it is very frustrating how long it is taking. We had a simplistic view that if we brought all the community together and provide the evidence, then things would happen.
Yeah.
Certainly, I think you have to look, as I said, at that bit I said about what is important to them. And so you have to sort of look at what is your sort of national plan regarding health and where the priorities are, and where you can argue that musculoskeletal health is important. So in the UK, our government became very concerned about the cost of work loss and disability, and looked at the data and saw that it wasn't cancer, it wasn't heart disease, but it was musculoskeletal health and mental health were the top causes. And we got invited to the table. And whenever they started talking about mental health, I would put my hand up and say,
hello? Can you hear me?
Mobile and be able to get out and about is very important for mental health.
Hello, can't hear you.
Sorry, can you hear me now?
Yeah, now you're back. Yeah.
Yeah, so you had to get to the table and find a way to get to the table, and then keep putting your hand up and highlighting how mobility is important. But it is a challenge, and that's why we really need also the top-down approach to get the WHO to put it on their list, because I know a lot of countries, particularly lower middle-income countries, are influenced by that. So I think we have to do that, and that's what we're working on. And so for that, we're selecting just a few countries where we think they're sort of amber or green in terms of their priority. And so I think, even if you can do it in your locality, your city, I think if we can get some good examples, that it's a lot of things we want to happen are not rocket science. Yes, some of those drugs we've been hearing about are frighteningly expensive, but there's also some very simple low-cost interventions which can be done. So we need to highlight that. And I think this is why we all need to work together and share these challenges.
Yes. I would now ask Professor Atik, who is here, who is the convener of the SIG. And I think he has managed this very well with the second conference. We are already going through, this experience of working together. Professor Atik, would really want to hear your comments, because I think we are already trying and working for increasing the workforce, which is, I think, is the most important need as well. And he and the SIG, and the SIG is under his leadership working towards building up that workforce. So, Professor Atik, we'd like to hear your comments. And
Prof Haq, please unmute yourself, Prof Haq.
Atik, unmute your.
Okay, thank you very much. I am actually in a moving vehicle, so my words may not be very distinct, but I must thank Professor Anthony Wolf for agreeing to our request for giving his talk, and his talk was really excellent. And so I also, thank Professor Nighat for shouldering the responsibility of moderating this, because I am on a holiday, and actually it was very difficult for me to attend. How anyway I could attend. Anthony, thank you very much. Thank you.
That's right.
Thank you so much. Yes, thank you so much. It was an Eid. Yeah, it was Eid today, so we canceled the family lunch and said, forget it. We can't miss this great opportunity to hear Professor Wolf. So we'll work together, and hopefully we will bring a change. I think we have committed ourselves, and in that respect, we have.
Yeah. Okay. I suppose one message I would say is this thing of working with other stakeholders. And I know this is the rheumatology community, but I've learned that sometimes there's quite a lot of power within the orthopedic community and the rehab community. And I think that's where we have to work out, seeing that there's a common win-win if we gain priority.
Nighat.
Yes, Nighat. Thank you so much. Yes.
Hi, listen. Thanks. Can I please
have
a question? Yeah,
yes, sure. Go ahead.
I am
please,
Nazrul.
please.
I am
yes,
Nazrul from Bangladesh.
Yes.
Yeah,
yes,
yeah. Anthony. Professor
Hello.
Anthony, it's Nazrul from Bangladesh.
Hi.
Yeah. So as before, the very nice talk from you, but possibly I realized that we are in need of have the further data from recent onward, from now onward. Are you in plan of developing any questionnaires that can be incorporated in our COPCOD questionnaire, so that when we are doing any COPCOD study, so from there you can have a good amount of data for the future reference? Are you thinking of that?
I agree that we need better data, particularly on impact and understanding the impact in different types of localities, environments of different conditions, because I think the impact of having a painful condition limiting your mobility in a westernized city may be totally different to a low and middle income rural village. So I think we do need to improve that understanding, because the weakness of the global burden of disease data is that a lot of it is modeling, where they try and find what they think is the best data, and if there's a model it for a country. So but I think the practical thing, going back to what you're saying, is for us to work together. And so the COPCOD group work with the global burden of disease group to make sure that the right data is being collected.
Yes, there is.
Yeah.
Thank you so much. There's a question by Binet Vaidya from Nepal, that how can we incorporate and study different models of care in rural and urban areas of low middle income countries?
So I think the main thing is to know about those models of care and understand, because again, I was recently gave a similar talk to the APLAR conference, and I'm sure the same is across APLAR. A lot of the models of care are developed in the USA or Europe, and then you're trying to implement them in totally different health settings. And so I think we need to make sure that models of care are appropriate to the setting they're being delivered in. And I think that needs actually perhaps going through what is considered to be the sort of international recommendations and highlighting what is feasible and what isn't feasible to try and get it realistic.
And Nazrul's idea of including in the COPCOD study is great. We have Arthritis Care Foundation developed 10 years ago, which is trying to address all these on our local level. And I think this model can work for training, for education, and for giving care to patients and for their medication. And I would really like to share that model with low-income countries, because it has worked wonderfully well for us. I'm so happy that we did that at the micro level, at least. But as you say, we have.
I agree, it would be very good, and something perhaps APLAR could do, or the SIG could do, would be developing a repository of models of care that people are using, care pathways that people are using in different countries.
Any more questions? I think Dr. Said, would you conclude it? I always learn a lot, Professor Wolf, whenever I read what you have done and the solutions and your journey, and you're not giving up on this. That's fantastic role modeling for us. Professor Atik, you want to give the concluding remarks? And have we lost Atik? Atik? Okay.
Yeah.
Okay.
Thank you very much. You know, in APLAR, actually, we are, trying to lead our, social commitment and patient outreach SIG so that it can arrange, organize data collection, building up the evidences in collaboration with, of course, the APLAR COPCOD. So I think we shall come up with more data and we can engineer, as Professor Wolf has said, on behalf at least at the macro and meso level, we can make some impact. That will be our target.
Yes.
Yeah, and I think this have been very clearly highlighted by Professor Wolf. And thank you all, and I also thank the audience. Thank you very much.
Thank you so much. Thank you, everyone. Thank you, APLAR. Thanks for having us.
Thank you.
Thank you. Thank you. Have a nice evening. Take
Thank
care.
you, Professor Ahmad,
you,
as well as Professor Wu, for the kind sharing. We are coming to the end, and now let us invite our Vice President, Dr. Lorenzo, to give us the closing remark. Dr. Lorenzo, please.
Well, good evening, everyone. Thank you to everyone who has stayed on, all the attendees who have listened throughout the talks, and of course to our speakers, and for giving us your very valuable expertise on the different SIGs. We had, I think, not all SIGs were represented. And so hopefully in the next midterm symposium, we can have everyone represented. We have, I think, 16 SIGs and 13 were able to participate in this talk. So in behalf of our APLAR president, Professor Debashish Danda, and the APLAR Academy, and the convener was here earlier, Professor Laishan Tam, I'd like to formally conclude this midterm symposium. Thank you very much.
Thank you, Lorenzo. Now we come to the end of the whole APLAR midterm symposium. We thank you all the participants for joining us to the end of the day. Wishing you all the best for the day, and may you continue to join us for the ACR ASM tomorrow. Thank you.